My name is Dr. Chandani. I'm your pediatric faculty at Medico. So this is going to be a live session, your final revision series in the subject of pediatrics. Actually, this is the second part of the revision. We have already done a live about 2 to 3 weeks back. So today in this 8-hour long session, we'll try to discuss those topics which is left behind. So first we'll start with the newborn. Okay, so the first question what we have here is a child. What is the age of the child? It's a 34 weeks gestation old baby, 34 weeks with a birth weight of 3 kg. Okay, and how does the baby look? The baby looks plethoric with a plumpy face, buried eyes and excessive buccal fat. And what they are asked is that which of the following maternal conditions is associated with this condition? So let's look at this question. Here they have given a 34 weeks gestation baby. So it's not a term baby, it's a preterm baby. Okay, it's a preterm baby at 34 weeks of gestation. But if you look at the birth weight, it's 3 kg. It is almost that of a birth weight of a term baby. So with respect to this gestation, this 3 kg cannot be taken as normal. So it is a large for gestation age baby. Okay, so that is the first clue that you have to pick out from this question. And how does the baby appear? The babies appear plethoric. And the baby has a plumpy face with buried eyes and excessive buccal fat. So all these features are consistent with the diagnosis of infant of diabetic mother. That is, the mother should be having gestational diabetes, and that has resulted in these changes in the newborn baby. So the right answer is diabetes. Gestational diabetes mellitus, to be precise. Okay, now first let's look at what is macrosomia. What is macrosomia? Macrosomia is if the baby is too large for the gestation age. That is large for gestation age. And that is said when the birth weight of the baby is more than 90th centile. That is birth weight more than 90th centile. Okay, according to the ACOG recommendation, macrosomia is defined if the absolute weight of the baby is more than 4.5 kg. According to ACOG, it is birth weight more than 4.5 kg, that is American. When according to Indian standards, in Indian population, the normal birth weight of a baby is around 2.5 to 3 kg. So in Indian scenario, if the weight is more than 4 kg, then also we can call it as a macrosomic baby. Okay, now what are the causes of macrosomia? The causes of macrosomia are predominantly two in number. The most common cause is maternal diabetes mellitus, that is infant of diabetic mother. Second, it could be a reason of a result of maternal obesity. And the third most common reason is, it's not very common, but there are certain overgrowth syndromes. That is, the baby is having a somatic overgrowth like Soto syndrome, Weaver syndrome, etc. In such cases also, the baby may be having a large first gestation age. So, overgrowth syndromes. Okay, now let's look into some of the salient points of an infant of diabetic mother. So what is the basic pathology? In a mother who is having diabetes, what is it actually? It is a stage of insulin resistance. That the mother is having a high level of resistance towards insulin. So what will the mother resultantly have? The mother will be having hyperinsulinism. And because of the hyperinsulinism in the mother, there is resultant hyperinsulinism in the baby. Okay. So the hyperinsulinism in the baby results in this overgrowth. Why? Because insulin is an anabolic hormone and it stimulates the growth of all the tissues of the body. So the first important problem faced by an infant of diabetic mother is hyperinsulinism. And that is responsible for the overgrowth or macrosomia. And does all the organs overgrow? No. All the organs in the body are large in a child with a mother having diabetes mellitus except the brain. That is, you may get an MCQ like all the organs in the body of an infant of diabetic mother will be overgrown except. The right answer is brain. So all organs increase in size except brain. And the child may even have microcephaly. Uncontrolled gestational diabetes mellitus is one of the reasons for microcephaly. It's not that all these children will have microcephaly, but it can cause microcephaly. So this is an MCQ point. All organs except brain. Okay. Then, as a consequence of this hyperinsulinism, what happens? The baby is having very high levels of insulin in the body. And because of this hyperinsulinism, the baby once born has a higher risk of developing hypoglycemia. So, the baby has increased the risk of hypoglycemia. And that is why all infant of diabetic mothers should be monitored by GRBS monitoring. Okay, so GRBS monitoring is mandatory for infant of diabetic mothers because they have a higher risk of hypoglycemia. The third metabolic complication of an infant of diabetic mother is the risk of hypocalcemia. They have a higher risk of developing hypocalcemia. The most common manifestation of hypocalcemia is jitteriness. It may also present as neonatal seizures. Jitteriness is the most common manifestation. It can also present as neonatal seizures. And what is the definition of hypocalcemia? Serum calcium less than 7 or ionized calcium less than 1. That is the definition for neonatal hypocalcemia. This is an important MCQ point. Okay. Then, the fourth important risk factor is they have a plethoric. The question is if they have said that the baby was looking plethoric. And why does this plethora happen? The plethora is because the babies are having polycythemia. So, the fourth problem is polycythemia. And because of this polycythemia, what happens? All these excess RBCs undergo breakdown and they are at higher risk of developing neonatal jaundice. And what happens is the fifth important complication is obstructed labor because the baby is a very large baby. So if you're trying for normal delivery, there is increased chances that the baby will have obstructed labor because of the large size of the baby. So obstructed labor and birth injuries are also common in infant of diabetic mother. Birth injuries like shoulder dystocia. And diabetes in the mother also makes the child at higher risk of developing certain congenital anomalies. And the most important one is cardiovascular anomalies. So what are they? So they have increased risk of congenital anomalies. It can either be cardiovascular or CNS. Among the cardiovascular, you can again divide into most common. The most common is asymmetrical septal hypertrophy, that is ASH. Asymmetrical septal hypertrophy and VSD. These are the two most common cardiovascular manifestations, cardiovascular complications of infant of diabetic mother. But if they ask which is the most specific, then you have to write the answer as TGA. The most common is ASH and the most specific is TGA. And the CNS, it mainly causes neural tube defects. And if they ask which is the most specific neural tube defect or the CNS malformation, then it is something known as sacral agenesis. So what happens? Both the limbs will be fused together. So it is also known as something known as mermaid syndrome. The most specific being sacral agenesis, also known as mermaid syndrome. Okay, so these are the important topics under the heading of macrosomia and infant of diabetic mother. I hope it is clear. So now let's move on to the next question. So here we have a premature baby. Okay, a premature baby has developed respiratory distress syndrome. Okay, so an important complication of prematurity is something known as hyaline membrane disease or respiratory distress syndrome. So what they've asked is which cells are defective in baby. So they're asking about the mechanism of respiratory distress syndrome or hyaline membrane disease. So let's briefly look at what happens in respiratory distress syndrome because it's a very important topic. We'll try to discuss it in detail because multiple MCQs have been asked from this particular area. Okay, so respiratory distress syndrome or hyaline membrane disease. Now, what is the population of children who's at risk of developing this RDS or HMD? It mainly affects premature babies. And what prematurity? Gestation age less than 34 weeks. Okay, so the risk factor for developing this is prematurity. And if specifically they ask the gestation age is always gestation age less than 34 weeks. And the second important risk factor is again infant of diabetic mother because this excess amount of insulin and glucose in the maternal blood will interfere with the production of the surfactant. So infant of diabetic mother is another risk factor apart from prematurity. Okay. Now let's see some important points about surfactant. So what is surfactant? Surfactant is actually a mixture of three different components. And what are these components? The first most important component is phospholipids. That is the most important component of surfactant. And the most common phospholipid is lecithin, also known as phosphatidylcholine. This has been previously asked as an MCQ, which is the major component of surfactant. Okay. Now, what are the other components? It contains something known as surfactant proteins. Surfactant proteins, also known as SPA, SPB, SBC, etc. These are certain surfactant proteins are present. And the third component is neutral lipids. So these are the major composition of the surfactant. And now the question, who or which cells release the surfactant? The surfactant is produced by a particular cell known as type 2 pneumocytes. The surfactant is released by the type 2 pneumocytes. And in the type 2 pneumocytes, this surfactant is stored in certain bodies and these bodies are known as lamellar bodies. They are stored in lamellar bodies and the stored surfactant is released out through a process known as exocytosis. Each and every word I am talking about is an MCQ. Type 2 pneumatocytes stored in lamellar bodies, released in exocytosis. Everything is an MCQ. Okay. Now let's look at what does a surfactant do. Why is surfactant so important? What happens if surfactant is not present? So what the surfactant does is that the surfactant reduces the surface tension. So when the surface tension is reduced, it prevents the alveoli from collapsing. So what if there is no surfactant? Because if there is no surfactant, the alveoli will be in a collapsed state and it will not expand when the baby is born. So if the alveoli does not expand, the gaseous exchange will not take place and the baby will develop something known as respiratory distress syndrome. So the function of surfactant is to reduce the surface tension and hence it prevents alveolar collapse. Okay, so physiologically, the body or the fetus secretes surfactant so as to ensure that the alveoli don't collapse and the baby can breathe normally when it is born. And at which age or which gestation age does the surfactant production starts? By 28 weeks of gestation, surfactant starts appearing in the amniotic fluid, but it's just the beginning. The complete surfactant synthesis is completed only by around 34 weeks of gestation. And that is the reason why any baby who is born before 34 weeks of gestation have higher risk of developing respiratory distress syndrome. So, surfactant appears in the amniotic fluid by 28 weeks and completed, or the lung maturity is fully attained by 34 weeks. Important. 28 weeks, first appears, lung maturity 34 weeks. Important. So, if the baby is born before 34 weeks of gestation, what are the clinical manifestations that the baby can develop? The clinical manifestations the baby can develop include respiratory distress soon after birth, RDSAB, and the scoring of this respiratory distress in the baby is very important. That is, we have two scoring system. If it's a term baby, that is, term means any baby born after 37 weeks of gestation, that is 37 completed weeks, then you call it as a term baby. And if the baby is born before that, you call it preterm baby. In the case of a term baby, the scoring system that we use is known as Downey score or modified Downey scoring system. This is used for term babies, that is more than 37 weeks of gestation, more than or equal to 37 weeks of gestation. Now, this is a very important MCQ. Multiple MCQs have been asked from Downey score, so you have to study this. So, what are the components or what are the parameters that you look in Downey score? The first one is the respiratory rate, and the scoring is in 0, 1 and 2. If the baby is having a respiratory rate of less than 60, it means that it is almost normal. In a newborn, any respiratory rate less than 60 is considered to be as normal. So if it is less than 60, the score is 0. The severity scoring is 0. There is no severity. If it is between 60 to 80, you give a score of 1, and more than 80, it is 2. The second one is cyanosis. If there is none in room air, it is 0. If no cyanosis with oxygen support, with how much oxygen support? 40% FiO2. If you are giving up to 40% FiO2 and the saturation is maintained, then you consider as a score 1. If the baby is require an FiO2 of more than 40% to maintain saturation, then you give it a score of 2. That is, FiO2 requirement is more than 40%. Now, the third one is retractions. In zero, no retractions 0, mild retractions 1, and moderate to severe retractions, you give a score of 2. Grunting. Grunting is expiration against a closed glottis. So what happens is that you see that's basically a disease of an indication that the child is having severe parenchymal damage. So the grunting, if it is not heard, it is 0. Audible with stethoscope, then score 1, and audible without, even without stethoscope, you are able to hear the grunting, then you give it a score of 2. Air entry, if it is good, 0, decreased, and the score is given as 1, and if it is barely audible, the score is given as 2. So we have 5 parameters, and the highest score is 10. That is the maximum severity. So you grade it as 0, less than 3, mild disease, 4 to 6, moderate, more than or equal to 7, it is severe, and this may even require intubation and ventilation, with or without surfactant. Surfactant might be required. Okay, so this is how you score Downey score. So in you might get a question like they'll give the parameters and they'll be asked, you'll ask me what is the scoring or what is the severity, and then even ask what is the management option that you have to provide. So that is the importance of Downey score, and it is done for term babies. Now what if it's a preterm baby? If it's a preterm baby, you have another scoring system, and that is known as Silverman-Anderson scoring. Silverman-Anderson scoring. Sometimes they may call it as SAS score. And that is used for preterm babies of less than 37 weeks. What are the components? The components are upper chest retractions, lower chest retractions, xiphoid retraction, flaring of the alien AC, and expiratory grunt 1, 2, 3, 4 and 5. And the scoring is again 0, 1 and 2. Okay, upper chest retraction, if it is synchronized, 0. Lag on inspiration, you give grade 1, and seesaw respiration, grade 2. Lower chest retraction, no, just visible, marked. Cephoid also none, just visible, marked. Nair, none, minimal, marked. Expiratory grunt, none, heard with stethoscope, audible without stethoscope. That is all very similar to Downey score. So you can remember the scoring as X lung. That is a code you use, the parameters. X stands for cephoid retraction. L stands for lower chest retraction. U stands for upper chest retraction. N stands for nares dilation, that is the flaring of the alien AC. And G stands for grunt. So the code is X lung. Okay, and the scoring is similar. That is, any score of greater than 7 means that the child is in respiratory failure. Similar to Downey score, and the child may require elective ventilation with surfactant therapy. So, what is the management options? Management options is basically you have to, this is a condition where you are having defective surfactant. But what if they ask a question like, what is the treatment of choice for management of respiratory distress syndrome? The answer is not surfactant, the answer is CPAP, that is continuous positive airway pressure. So the treatment option both for preterms as well as term babies, what you do is the CPAP. The treatment of choice is CPAP, continuous positive airway pressure. And if after giving 1 hour of CPAP, still if the patient is requiring an FiO2 of more than 40%, so you put the child in CPAP and you wait for 1 hour, and at the end of 1 hour the baby improves, then you can continue CPAP and slowly wean off. If after 1 hour the baby is not maintaining or requiring an FiO2 of more than 40%, then it is considered as CPAP failure. And in which case you have to give surfactant, exogenous surfactant. So surfactant is deficient, so you give surfactant. And how is surfactant given? Surfactant is given by 2 methods. The one method is insured. That is intubate. Surfactant is given and extubate. That is, you intubate the baby, you give the surfactant through the tube, then you give some bag and mask ventilation to recruit the surfactant throughout the lungs, and then soon after you extubate and connect the baby back to the CPAP. That is the insured method. That's a classical method that we used to practice. Now there are certain recent methodologies that have come known as MIST or LISA. MIST or LISA. And what is MIST? MIST stands for Minimally Invasive Surfactant Therapy, MIST, Minimally Invasive Surfactant Therapy. And LISA stands for Less Invasive Surfactant Administration. These are the same, different terminologies for the same procedure. Here you are not intubating, you are just introducing a nasogastric tube. And through this nasogastric tube, without using an endotracheal tube, you are giving the surfactant to the lungs itself. So this is a lesser invasive. There is no intubation taking place. So the nasogastric tube is not going to the stomach. The nasogastric tube is going into the trachea, and through that you are giving the surfactant. So if they ask which is the newer modality of treatment for surfactant administration, you can give the answer as MIST or LISA, minimally invasive surfactant therapy or less invasive surfactant administration. So that is the treatment. Now, another important area is, how do you prevent this? What are the measures that you can take to prevent or protect a baby from developing RDS? So, if you know that a mother who is less than 34 weeks of gestation is going in for labor, or there is an impending delivery, there are certain measures that you can do before the baby is born so that the lung maturity can be accentuated, or you can speed up the lung maturity. And that is by giving corticosteroids. You give steroids. That is antenatal steroids. And how do you give these antenatal steroids? These antenatal steroids, you have two different regimens. You can either give betamethasone or you can give dexamethasone. The betamethasone, the dose is 12 mg. And you give it Q 24 hourly. How many doses? 2 doses. What is the route? Intramuscular. Dexamethasone, the dose is half, 6 mg. But you give it 12 hourly. The other one was 24, this is 12. 12 mg dose, 6 mg dose. So all half divided by 2. And how many doses? You give it 4 doses. The other one was 2 doses, you give 4 doses. And the route of administration is intramuscular. And when should this be given? At least 24 hours before delivery. So if the baby comes, a mother who is at premature and comes to you in contractions or in impending delivery, you give the antenatal steroid and you try to complete this total dose of steroids, either betamethasone or dexamethasone, and you try to have a 24-hour period so that the steroids can act and the lung maturity is acquired to some extent so that the baby's respiratory distress after birth can be controlled to some extent. Okay, so if the baby doesn't deliver, you took all the measures and the delivery did not happen. So when can you repeat it? So if more than 7 days has passed and then the mother is again going in for labor, then you have to repeat it. So if more than 7 days have passed after giving the first dose and then the mother is going in for delivery, then you have to give a repeat dose. And at what gestation age? 24 weeks. Mothers between 24 weeks to 34 weeks of gestation, you give antenatal steroids. So more than 34 weeks, there is no need. Less than 24 weeks, you cannot salvage the baby. So all these mothers coming to you between the gestation age of 24 weeks to 34 weeks in impending labor, and if the delivery is expected, always remember to give antenatal steroids. Okay. So that is about respiratory distress syndrome. Now, next question. What is the delivery procedure to be done in a newborn with a meconium stain like? So here you have a baby who is having an in utero passage of meconium. So meconium, as you all know, is the first stool that the baby passes. And usually this meconium is passed after the baby is born. Right. But if the baby, what happens if the meconium is passed inside, in utero? What happens? This meconium gets mixed with the amniotic fluid and the baby can aspirate this amniotic fluid. This meconium stained amniotic fluid, and this can be aspirated into the lungs and can cause something known as chemical pneumonitis or meconium aspiration syndrome. So previously there were separate guidelines to manage a meconium stained amniotic fluid baby and another respiratory distress baby or a baby who didn't cry soon after birth. But now the consensus is that you manage a meconium stained amniotic fluid baby in the same way as any other baby. There is no separate recommendations. So no additional intensive measures or additional interventions is recommended for a meconium stained amniotic fluid baby now. So that is a new consensus. So this question is trying to ask about that particular area. So let's look at the options. So they are said before delivery before delivery of the shoulder, suctioning of the mouth and the nose. This was previously recommended, but now it is not recommended. So this is not done. PPV, that is positive pressure ventilation in non-vigorous child after initial steps. Yes, that we do in all the babies, including an meconium stained baby. Gentle suctioning of vigorous baby. Yes, that also you do. Tracheal suctioning followed by mouth suctioning. That used to be done previously. You used to suction into the trachea and remove the plugged meconium. But now it is not done. So the right option is 2 and 3. So the key concept that you have to study here is that the management of a baby with in utero passage of meconium is similar to any other baby. No separate steps or interventions are undertaken for a meconium stained baby. Okay. So that's about the little points about meconium. As I've said, meconium is the first tool, right? And when should be a normal meconium be passed? A meconium should be passed within 24 hours of delivery. Should be passed within 24 hours. And after meconium, there is something known as transitional stool. So first what the baby passes meconium, and later it's get converted into something known as transitional stools. That is what is passed between 3 to 4 days of life. And after that, the baby passes something known as golden yellow breastfeeding stools. So meconium should be passed within first 24 hours. And when should urine be passed? Urine should be passed within the first 48 hours. Okay, so urine 48 hours, meconium 24 hours. Now, what is the main content of meconium? More than 80% of the meconium contain water. More than 80% content is water and also contains certain denuded epithelium and certain enzymatic products, etc. And what is the color of meconium? It is greenish in color. Green color. And what are the causes of delayed passage of meconium? So I said that normally a baby should pass the first meconium within 24 hours of life. What if the baby doesn't pass? What are the causes of delayed passage of meconium? Delayed passage of meconium can occur because of surgical causes as well as medical causes. First, let's look at the surgical causes. What are the surgical causes? For example, if the baby is having certain obstruction in the passage of the meconium, it could be an anorectal malformation. That is, the anal canal is not developmentally normal. So, the most common surgical cause is anorectal malformation. Or it could be some other diseases, obstructive disorders of the intestine like Hertzsprung's disease. HD or Hertzsprung's disease. Now, what are the common medical causes of delayed passage of meconium? It could be because of hypothyroidism, congenital hypothyroidism, or it could be something known as meconium ileus, where the meconium gets plugged in the ileum and it is usually seen as a part of a disease known as cystic fibrosis. Okay, so these are some of the causes of delayed passage of meconium. Now, last, what if the baby aspirates this meconium? Then the baby develops something known as meconium aspiration syndrome. And what is the characteristic X-ray finding in meconium aspiration syndrome? It is known as sunburst appearance. The X-ray appearance is known as sunburst appearance. MCQ. And what is the most common complication associated with MAS? It is associated with PPH, persistent pulmonary hypertension. So that is also an MCQ. The complication associated with MAS is PPH. Okay. Now, which are the babies who are at risk of developing meconium aspiration? It mainly occurs in post-term babies or near-term babies. And if there is any intrauterine fetal distress. Then also if the baby is having any distress, the baby will pass the meconium in utero, or if the baby has been in the uterus for too long, that the post the term gestation, then also the baby can pass meconium in utero. So the risk factors is post-term baby and if the baby is having any intrauterine fetal distress. So these are some of the important points about meconium aspiration syndrome. Now let's look at very important high yielding area, very hot topic, that is neonatal resuscitation protocol, NRP. So, what is neonatal resuscitation protocol or NRP? In NRP, what they are doing is that what are the steps or the protocol for management of a baby if the baby doesn't cry soon after birth? So, normally when there is a transition from the intrauterine to the extrauterine life, then the transition is mediated by the cry, the first cry. The first cry of the baby, it points towards the expansion of the lung. So if there is transition doesn't take place normally, maybe because of fetal causes, maybe because of maternal causes, or because of the perinatal causes, difficult labor, obstructed labor, prolonged second stage of labor, or if there is any birth injuries like instrumental delivery, etc., this transition might not take place normally. So what happened? The baby will fail to cry soon after birth. So if the baby fails to cry, what happens? The lungs won't expand. If the lungs won't expand, the oxygen, when the baby is inside the uterus, the placenta is supplying for the baby. But once the baby is outside, the baby has to respire on its own. But if the baby fails to do that, what happens is that there will be hypoxia. There is decreased oxygen concentration in the baby's body, and this hypoxia can affect all the functioning of all the organs in the body. And the most important organ that can be affected is the brain, and can result in something known as HIE, or hypoxic ischemic encephalopathy, which is a very grave complication and can even lead to multiple sequelae, including cerebral palsy, seizure disorders, etc. So in order to prevent such a big problem, simple steps which can be done in the delivery room can prevent all this. So these steps are briefly summarized in this NRP, or neonatal resuscitation protocol. This is a very important topic both for practical purposes as well as for your entrance point of view. Okay, so first let's start with 4 pre-birth questions. So before the baby is born, we have to make a team briefing, and you prepare the team, and the pediatrician should ask the gynecology team certain pre-birth questions so that we ourselves can be prepared before the baby has come to us. So what are these 4 pre-birth questions? The 4 pre-birth questions are, one second. Okay, so Akhil Tota has asked about the treatment of PPHN. So PPHN is a complication of, as I've already said, meconium aspiration syndrome. So from pediatric point of view, when a child is having PPHN, you generally diagnose it by looking at the child, that the child will be having failure to maintain the oxygen saturation, and it will be disproportionate to the respiratory distress. And if you look at the compare between the upper limb and the lower limb saturation, there will be a difference of more than 10%. That is, if the upper limb saturation is 98, the lower limb saturation should be above 88. But if the difference is more than 10%, for example, upper limb is 98, but the lower limb is only 80%, then you call that the child is having PPH, and that is how we make a diagnosis. So the treatment of PPH is multimodal treatment. The initial small steps that you can take for prevention or the treatment of PPH is to keep the child sedated, avoid stress and excessive movement, and you also prevent excessive stimulation of the child. All this excessive light, sound, suctioning, all that should be reduced, and you have to adequately sedate the child. And then you have measures to reduce the PPH. What happens is the pulmonary pressure is high. So what happens is that there will be increased shift from the right to left. That is, from the pulmonary to the systemic, there is excessive shunting of blood. So what you have to do, you have to reduce the pulmonary pressure, or you can increase the systemic pressure. To decrease the pulmonary pressure, you have certain medications known as sildenafil. Sildenafil is a phosphodiesterase inhibitor, phosphodiesterase 5, PDE5 inhibitor, that is commonly used for the management of PPHN. And you also have bosentan, that is another drug which can be used. And there are certain drugs to increase the systemic pressure. The systemic pressure can be increased with the help of inotropes like norepinephrine, or epinephrine can be used. And if the PPH and all these measures fails, then the final or the most important treatment that you can provide is by inhaled nitric oxide, INO. INO can also be used as a treatment for PPH. Okay, I hope you have cleared your doubt. Now moving on to the, let's continue with the NRP, that is neonatal resuscitation protocol. So the first is you have to do the team briefing, equipment check, and then you have to ask 4 pre-birth questions. And what are these 4 pre-birth questions? The 4 pre-birth questions is, the first one is gestational age. You want to know whether you are going to deal with a preterm baby or a term baby. So the first question is gestational age. The second question is the amniotic fluid color. What is the color of the amniotic fluid? Whether it is clear or it's a meconium stained amniotic fluid. Then, what are the additional risk factors? That is, does the baby have some cardiac complications? Does the baby have some anomaly scan done, and whether there is any defects? Or is there any other risk factor, maternal or fetal risk factor, that you should be aware of before resuscitating the baby? For example, the baby is having congenital diaphragmatic hernia. Do you all know that bag and mask ventilation is contraindicated if the baby is having CDH? So you should know about all these risk factors so that you can resuscitate properly. Then finally, you have something known as umbilical cord management plan. Okay. So again, Akhil Totta has asked upper limb, lower limb respiratory difference in PPHN or coarctation of aorta. In both PPHN as well as in coarctation of aorta, you can get this upper limb, lower limb saturation difference. In coarctation of aorta, you will also get feeble pulses in the lower limb because there is obstruction beyond the bifurcation. So what happens is the lower limb pulses will be weak and the lower limb saturation will also be weak. But in PPHN, there will be only be saturation difference. The volume of the pulses will be similar in both the upper limb as well as in the lower limb. Okay. Now, so now we have dealt with the 4 pre-birth questions, that is gestation age, amniotic fluid color, risk factors and umbilical cord management plan. What is umbilical cord management plan? If the baby is having a normal baby, a term baby, you do something known as delayed cord clamping. Is something known as delayed cord clamping. So what you do is that you delay the clamping of the cord to 30 to 60 seconds. So what happens? The additional amount of blood can flow from the mother to the baby. But if the baby is having some distress at birth or the baby doesn't cry soon after birth, then you cannot wait for this 30 to 60 seconds for the umbilical cord clamping. So in such situations, you will skip the delayed cord clamping and you will quickly clamp the cord. So that is, you have to know about the umbilical cord plan, whether you have to go for delayed cord clamping or you can wait, or you have to immediately cut the cord and take the baby for resuscitation. Okay, so if it's a high risk baby and if the baby has some issues during this transition period, you will not go for delayed cord clamping. Okay, so these are the 4 pre-birth questions. This is a recent modification of NRP, so it's a possible MCQ for you, because in the previous pre-birth questions, the question was how many babies. Now the how many babies question has been changed to umbilical cord management plan. So this can be a possible MCQ for you. Okay, now what are the initial steps? So let's briefly look at the steps of the NRP and then we'll look at this chart. Okay, so first I'll tell you what are the steps in NRP. So first is antenatal counseling, team briefing and equipment check. Okay. And after that, you look at 3 important points, whether it's a term baby, whether the baby is having a good tone and whether the baby is breathing or crying. So term, tone and the cry. These are the 3 important things that you look at when the baby is born. If all these are normal, then it is a well baby. Then you can go on with a normal newborn care. So if the baby is not term, or if the baby is not having a good tone, or if the baby is not crying or breathing, then means it's a risk factor. In which case you have to go with the initial steps. And what are these initial steps? Warm, dry, stimulate, position airway and give suction. So warm, dry, stimulate, position the airway and then suction if needed. These are known as the initial steps of resuscitation. And after these initial steps, you see whether the baby is breathing or not. If still the baby is having apnea or gasping, or if the heart rate is less than 100, then it is an indication for starting bag and mask ventilation or positive pressure ventilation. Okay, this when you are starting positive pressure ventilation, you always connect a pulse oximeter and also consider collecting a cardiac monitor so you can look at the saturation also while doing the resuscitation. Okay. And if the heart rate, if after starting this PPV, then you again look at the heart rate. If the heart rate has improved, then means that your resuscitative measures have worked and then you can do the follow-up measures. But if even after giving this PPV, the heart rate is not improving, the heart rate is still less than 100, then what you can do is that you have to take certain corrective steps. And what are these corrective steps? These corrective steps are given by the mnemonic MR SOPA. That is, the positive pressure ventilation is most important. If the MCQ is asked, which is the most important measure to in the process or in the among the steps of resuscitation of a newborn baby, then the right answer is PPV. So the PPV should be given correctly in the right method. Then only adequate ventilation can be ensured. So if you're giving PPV and still the heart rate is not improving, it could be because of a technical error in your method of giving the PPV. So you have to take certain corrective steps that you can deliver the PPV correctly. And what are these corrective steps? The first one is M for mask reposition. For example, you have not kept the mask in the correct place. So mark reposition. Then R is for reposition the airway. The airway might be kinked, the neck might be flexed. You have to keep the neck straight and the airway should be straight. So that is repositioning the airway. And then S is for suction. For example, if there are a lot of secretions, your pressure will not be transmitted to the lungs. So you might have to give a suction if there is a lot of secretions. Then O is for opening the airway. If the positive pressure ventilation is not working, then you have to open the mouth also. So opening the airway. And then P is for check whether the pressure is right. If you are not giving adequate pressure, then also the PPV might not work. So you have to check the pressure. And finally, if all these steps are taken and still the heart rate is not improving, then you have to consider alternate airways. And the examples of alternate airways can be an endotracheal tube or a laryngeal mask airway. Okay, so consider ETT or laryngeal mask. If even after taking the corrective steps, the heart rate has not improved. And even after that, if the heart rate is less than 60, if the heart rate is less than 60, while on positive pressure ventilation, it is an indication for starting chest compression. So if in the question, the heart rate is less than 100, you have to go for PPV. If the heart rate is less than 60, then you have to give chest compressions along with positive pressure ventilation. So that is an MCQ point. And even after giving chest compressions, if the heart rate is less than 60, then it is an indication for giving drugs. And which drug? You have to give adrenaline. Okay, so let's summarize this again so that you'll have more clarity. So you have a baby. So you look at the tone. So the 4 pre-birth questions we already asked. Now the baby is born. You look at the tone of the baby, the cry of the baby, and whether the baby is breathing or not. If it is not happening, the baby did not cry, then what do? You first do the initial steps. And what are these initial steps? Warm, dry, stimulate, position, and suction if needed. And even after that, if the heart rate is less than 100, then you have to start positive pressure ventilation. And you give positive pressure ventilation, still heart rate is not improving. It is still less than 100. Then you take the corrective steps. That is MR SOPA. And even after that it is not improving, then you have to consider endotracheal intubation or laryngeal mask airway. And if the heart rate falls below 60, then you have to give chest compressions. That is CPR along with PPV. And when you are giving chest compressions, till that point, you were using FiO2. What is the FiO2 for resuscitation? The FiO2 for resuscitation depends on the gestation age. The baby is more than 35 weeks of gestation, you use 21% FiO2. If the gestation age is less than 35 weeks, you use 21 to 30% FiO2. So this is the initial FiO2 at which you start resuscitation, at the beginning of resuscitation. But once you start CPR, you have to increase the FiO2 to 100%. That is, if the heart rate is less than 60 and you are starting CPR, then you suddenly you have to increase the FiO2 to 100%. So FiO2 is kept 100%. And still the heart rate is not improving. It is less than 60. Then you have to give adrenaline or epinephrine. And what is the dose of adrenaline or epinephrine? It is 0.02 mg per kg. If it is given IV and the common IV route is via the UVC, or it is zero point 0.1 mg per kg. If you don't have an IV access, you can even give it intratracheally. The intratracheal dose is 0 0.1 mg per kg. Okay. So that is the method of resuscitation. Okay, this is the NRP, that is the neonatal resuscitation protocol. So some certain one-liners. What is the most important step in NRP? If they ask which is the most important step, the most important step is PPV. and which is the most sensitive indicator of successful resuscitation? If you are giving the resuscitation correctly, the first change that you can look up for the child is not the saturation but the heart rate. If the heart rate improves, then you can be sure that the baby is responding. So the most sensitive indicator of successful resuscitation is an increasing heart rate. Increase in the heart rate. And then what is the MCQ about chest compressions? While you are giving chest compressions with PPV, the ratio in which you give is 3:1. That is 3 compressions followed by 1 breath. Okay, you give 3 compressions followed by 1 breath. That is the ratio. And there are 2 techniques. You can use one hand technique and 2 thumb technique. That is, either you can give CPR like this using your 2 thumbs or using single hand and 2 fingers like this. And which is the more preferred method? The 2 thumb method is the preferred method. Okay, so this is also an important MCQ. So here again a doubt in the comment box, someone has asked when to reassess after PPV. So at the end of 1 minute, so the entire step of PPV should take a period of 1 minute. At the end of 1 minute, you should make a decision that whether you have to go in for alternate airway. Okay, because after 1 minute also, if the heart rate is not improving, that is an indication for starting or considering an alternate airway. So the answer for that is 1 minute. Okay. Now, moving on to the next question. The correct order of suctioning during neonatal resuscitation is. So I've already said during the initial steps there is a clause known as suction. So how to give suction? The suction is always given in the mouth, then followed by the nose. So it is LMN in the alphabetical order. If you see M comes M, then N comes after M, right? LMN. So the order of suctioning is also same. It's first the mouth, then the nose. Okay. And what is the pressure? It should be 80 to 100. That's the pressure that should be used. So that is the correct order of suctioning during neonatal resuscitation. Routine suctioning is not recommended. Only if you feel that there is some obstruction, then only you should go in for giving a suction. Next, in a neonatal phototherapy, bilirubin is converted into. So here you have a question from neonatal jaundice. Okay, so neonatal jaundice, all the pathophysiological aspects of the causes of neonatal jaundice, how to assess neonatal jaundice, and what are the various blood investigations, initial investigations, all these things, and the bilirubin metabolism, everything we have already dealt in our previous live class. So if you want more information about this, please go and watch the previous live we have already done. Here we are going to discuss about the treatment part of neonatal jaundice. And the first line treatment for a child with neonatal jaundice is phototherapy. Okay, so you all know the treatment is phototherapy. So what does this phototherapy do? So in phototherapy, what happens is that there are 3 different reactions taking place. As given in this table, the first one is a configurational isomerization, then there is a structural isomerization, and then there is photooxidation. Okay, of this, the most important step is structural isomerization, because the structural isomerization is a irreversible reaction, and herein the bilirubin is converted into a soluble byproduct. And what is the name of the soluble byproduct? Lumirubin. That is the name of the soluble byproduct. And what happens is that the reaction is directly proportional to the dose of phototherapy, and this is the main responsible for reducing the serum bilirubin. So the major reaction which is responsible for reducing the serum bilirubin level, and it is directly proportional to the duration of the phototherapy, is structural isomerization, where bilirubin is irreversibly converted into a structural isomer known as lumirubin. Okay. Now, there is something known as configurational isomerization. But the configurational isomerization, the problem with this reaction is that it is a reversible reaction. Okay. It is converted into E isomers. It is a reversible reaction. And what happens is that the most of the bilirubin undergoes this configurational isomerization, but it does not form a major mechanism of reducing the serum bilirubin levels. The major mechanism is always structural isomerization. And then you have something known as photooxidation, which is also a minor reaction only. So the structural isomer is lumirubin. and that is what is being excreted out. Okay. Now, the factors affecting the efficacy of phototherapy is, one is irradiance. Irradiance is how much is the irradiance of the light, and the recommended nanometer at which you have to give phototherapy is 450 to 460 nanometer. This is the maximum absorption peak. The maximum absorption peak of bilirubin is if you are giving a light at a wavelength of 450 to 460 nanometer. Then surface area exposed. Always you have to keep the baby naked, just covering the eye area with the goggles, and you make the diaper area, you cover it using a diaper. The rest part of the body should be completely exposed. Distance from the phototherapy unit plays a part. Initial serum bilirubin level and the adequacy of breastfeeding. Only if the baby is adequately hydrated during the period of phototherapy, this excretion of all these products via the urine take place. So adequacy of breastfeeding also plays an important role in determining the efficacy of phototherapy. Okay. So that is about that. Now, what is the second line treatment? What if the phototherapy doesn't work, or if the baby is having very high bilirubin level? Then the second line treatment option is something known as exchange transfusion. And the exact terminology is double volume exchange transfusion, DVET. What we are doing is a double volume exchange transfusion. What are the indications for doing exchange transfusion? If the baby is having, if you look at the cord blood, if the HB is less than 10, or if the total bilirubin is more than 5, then it is an indication for exchange transfusion. And usually, in which babies are at high risk of developing this exchange transfusion? If the baby is having any blood group incompatibility between the mother and the baby, most commonly RH incompatibility, that is RH negative mother with an RH positive baby, and ICT, DCT positive. It means that there is exaggerated hemolysis. And because of this exaggerated hemolysis, there is increase in the serum bilirubin levels. And in which case, you have to remove all this bilirubin to prevent complications like kernicterus or bilirubin encephalopathy. So these are some of the important indications for doing exchange transfusion. And if there is an blood group incompatibility and excessive hemolysis, then another option that you can do is, another option that you can provide is IVIG, intravenous immunoglobulin. This is, we are giving exogenously, we are giving intravenous immunoglobulin, and these immunoglobulins will block the maternal antibodies, and this will help in arresting the ongoing hemolysis. So first line treatment is for phototherapy, second line is exchange transfusion, and if it's a DCT positive hemolysis induced hyperbilirubinemia, you can even consider IVIG. So these are the various treatment options for management of neonatal hyperbilirubinemia. Now we'll take a short break, and after that we'll continue. Okay, welcome back. Let's move on to the next question. So, what is seen in this baby with cerebral damage due to kernicterus? So, they have given in the question there is baby is having something known as kernicterus. So, we've already dealt previously about how to manage hyperbilirubinemia, right? So, what if we didn't manage hyperbilirubinemia or by hyperbilirubinemia went out of control? What is the complication the baby can develop? The complication is known as kernicterus. What happens is bilirubin, the unconjugated bilirubin is a very toxic product. Unconjugated bilirubin is a toxic product and it will cross the blood-brain barrier and result in injury to the brain. And which part of the brain is injured? It's the basal ganglia. The basal ganglia is the part that is affected the most. That is an MCQ. Resulting in a condition known as kernicterus. Okay. So that is kernicterus. And what does the patient have? What are the features of kernicterus? Kernicterus is manifested by 4 important features. First one is chorioethitoid CP. So since the child is having increased extrapyramidal features, and because of this extrapyramidal features or extrapyramidal symptoms, what happens is that there will be something known as opisthotonus. Opisthotonus is excessive arching backwards. You can see the baby is arched backwards like a bow. And this is known as opisthotonus, and this is because of the excessive extrapyramidal activity. So, opisthotonus. Then there is something, it can have cause sensorineural hearing loss. It can cause upward gaze palsy. And finally, enamel hypoplasia. So these are the 4 important manifestations of kernicterus. So coming back to the question, what do you see here? What you're seeing here is not neck rigidity, sorry. What you're seeing here is opisthotonus. Opisthotonus. That is the right answer. Okay, so that is about kernicterus. Moving on, what is the most common manifestation of neonatal sepsis? Now we have completed about the bilirubin part. Now we'll move on to another important area in newborn, that is neonatal sepsis. Okay, so what they've asked is what is the most common manifestation of late onset sepsis? So let's look about some of the important points in neonatal sepsis. Neonatal sepsis can broadly be classified into 2 types. It can either be early onset sepsis or late onset sepsis depending on the time. If it happens within the first 72 hours of life, then it is known as early onset sepsis. If it happens after 72 hours, then it is known as late onset sepsis. So EOS or LOS. EOS if it is less than 72 hours and LOS if it happens more than after 72 hours. Okay. Now let's look at what are the important organisms. Okay, the common organisms or the etiology of neonatal sepsis. This is a very important area because it is very confusing. Multiple MCQs have been asked from this area, so please pay attention. The most common, in general, if you ask us a one-liner, what is the most common organism which can cause neonatal sepsis? Then the answer is gram-negative bacilli. The most common is gram-negative bacilli or gram-negative organisms, not bacilli, gram-negative organism. Sorry. Gram-negative organisms. If you ask which is the most common organism in India, the most common organism causing neonatal sepsis in India is Acinetobacter. In India, it is Acinetobacter. Okay. Followed by Klebsiella. Now, which is the most common organism in the world? In the world, it is E. coli. Okay. Now, if about early onset sepsis, if yes, they are asking particularly about early onset sepsis, then the most common organism is group B streptococci. Okay. Now, what are the clinical features? What are the clinical features of neonatal sepsis? So the clinical features of neonatal sepsis, if it is an early onset sepsis, they usually present as either septicemia or pneumonia. Okay, they may present as septicemia or pneumonia. Whereas if it's a late onset sepsis, the most common manifestation is meningitis. This is an important area. Important MCQ area. Okay, so the question here is, what is the most common manifestation of late onset neonatal sepsis? The answer is meningitis. Okay. Now, what are the clinical features of neonatal sepsis? How would the baby present? The baby may present fever, poor activity, lethargy, poor feeding, and there can be temperature instability. In older children, whenever they get fever, you think about infection, right? But in the case of newborns, it's not like they will always get fever. They may even going for hypothermia because of the sepsis. So temperature instability can be either be hyperthermia or hypothermia, and they may even develop hypoglycemia. That is, if the baby whose term baby suddenly develops hypoglycemia, then that can also be one of the warning signs for neonatal sepsis. Okay, now if you are suspecting neonatal sepsis, how will you evaluate? What is the gold standard investigation? The gold standard investigation is blood culture. The gold standard investigation is blood culture. But the blood culture always takes time, right? If you send for a blood culture, it takes about 48 hours for that we get even a primary report. So there are certain other steps that you can do to screen whether the baby is having sepsis or not. That is known as sepsis screen. Okay, so now let's look at the next question, that is about sepsis screen. So they've asked, sepsis screen includes all the following except. So what are the components of the sepsis screen? The sepsis screen includes, first one is the total leukocyte count. The total leukocyte count less than 5,000, that is leukopenia, is considered as a risk factor for neonatal sepsis. Then ANC, absolute neutrophil count, if it is low. And how do you look at ANC? You have certain charts. If it's a term baby, there is something known as Monroe chart. And if it is a preterm baby or a very low birth weight baby, then you have something known as Mosino chart. Okay. Then you have something known as IT ratio. What is IT ratio? Immature is to total neutrophil ratio. That is IT ratio. If it is more than 0.2, then it is a risk factor for sepsis. Then the third one is micro ESR. If the micro ESR is more than 15 millimeter in 1 hour. And last one is C-reactive protein. So these are the components of the sepsis screen. So total leukocyte count, absolute neutrophil count, IT ratio, micro ESR and CRP. So here they asked, sepsis screen includes all the following except TLC, yes, absolute neutrophil count, yes, IT ratio, yes, but band cell count, no, it's not a part of the sepsis screen. Okay, so that is how you manage the important points about neonatal sepsis. Now, identify the procedure being performed in a baby admitted in NICU as shown in the given image. So what are they doing? What they have, you can see that the caregiver or the nurse, sorry, is passing a tube via the mouth. And once the tube is passed, they are giving a feed via this tube. So what is this? This is an orogastric tube. That is, they're inserting a tube via the mouth and it reaches into the stomach, and this can be used as a method of feeding. Sorry. Okay, that is known as orogastric feeding. So if the same tube is passed through the mouth, then what do you call it? Then you call it as nasogastric feeding. So the right answer here is orogastric feeding. So when do you use these methods? When do you use these other? Usually, if it's a term baby, you need not use all these methods. You can directly put the baby onto the breast, and the baby will suck from the mother's breast. But if the baby is born preterm or a premature baby, then you cannot start direct breastfeeding as soon as after birth. So in such conditions, you may have to opt for other feeding methods. So what feeding methods to take in each gestation age is an important MCQ question. So if the baby is born less than 28 weeks, then the baby has to be put on IV fluids. You cannot give oral fluids to that baby. You can only give small amount of colostrum. No big feeds can be given to the baby. So if the baby is before 28 weeks of gestation, you start the baby on intravenous fluid. If the baby is between 28 weeks, after 28 weeks, but before 32 weeks, then you give the baby feeds. Express breast milk can be given via an orogastric tube. If the baby is between 32 weeks to 34 weeks of gestation, then you can give the bead feeds with the help of a pallidi or a gogurnum. Okay, with the help of a pallidi or a gogurnum feeds. And if the baby is more than 34 weeks, then you can put the baby on direct breastfeeds. Okay, so that is if the baby is before 28 weeks, IV fluids, 28 to 32 weeks, you have to put her on OG feeds, that is orogastric feeds. 32 to 34 weeks, you can put them on pallidi feeds or gogurnum feeds. And if the baby is more than 34 weeks of gestation, then you can directly put the baby onto the breast and promote direct breastfeeding. Okay, so that is about the image and the feeding in a premature baby. Moving on to the next question. Which of the following medicines taken during pregnancy is responsible for the defect seen in this child? So what is the defect you see here? The defect you see here is a cleft lip. So among the drugs, which is a drug which can act as a teratogen? Ferrous sulfate, is it a teratogen? No. Isoretinone, yes, it is a teratogen. Folic acid, is it a teratogen? No. Folic acid is something you give to prevent neural tube defects. It is given as a therapeutic measure for prevention of neural tube defects. Metoclopramide, it's not a teratogen. So the right option. So basically, when you are preparing for an MCQ question, you need not always know the right answer. But if you can just rule out the other options, then also you have very high chances of getting the option right. So here, even if I didn't know which drug causes cleft lip and cleft palate, since I can rule out the other options, you can arrive at the right answer. So by eliminating the other options, we have come to the diagnosis of isoretinoin or vitamin A as the right answer. So let's now discuss some of the important points of vitamin A as a teratogen. Vitamin A or isoretinoin. What are the side effects or the teratogenic effects of vitamin A? It can cause craniofacial abnormalities like cleft lip and cleft palate. It can also cause cardiovascular effects or abnormalities, CNS abnormalities like hydrocephalus, microcephaly, ear abnormalities like sensorineural hearing loss, eye abnormalities like microphthalmia, skeletal abnormalities, and thymic aplasia. These are the other teratogenic effects of vitamin A. And about the other teratogens, we have already discussed about in our previous live class. So if you can please go and listen to that if you want to know more about the other teratogenic drugs in pregnancy. Okay, so that is just about vitamin A. Moving on to the next question, the components of kangaroo mother care include. So next, this is a very other important area, that is KMC, kangaroo mother care. So what is KMC? For which babies do you do KMC? KMC is a measure that you give in order to improve weight gain and to prevent hypothermia in premature babies or very low birth weight babies. So you do it for preterm babies or low birth weight babies. And what are the important components of KMC? The components of KMC include, the first one is kangaroo position. Kangaroo position. How did the kangaroo position? The baby sits, the mother sits up, the front part of the upper garment is opened, and the baby is put so that the tummy to skin contact. The baby is put in the on the mother's body in the prawn position, so that there is skin to skin contact between the baby and the mother. So kangaroo position, the most important core point is skin to skin contact. The second one is kangaroo nutrition. What is kangaroo nutrition? Whenever the baby is put in kangaroo mother care, you expect that the baby is on breastfeeding. That is exclusive breastfeeding. That is the second component of kangaroo mother care. Exclusive breastfeeding. Now, the third one is kangaroo discharge. Whenever the mother is put on kangaroo mother care, the baby and the mother is put on kangaroo mother care, the baby can be easily discharged from the hospital, early discharge, and even from the home, the mother continues to practice this kangaroo mother care. That is, the mother continues to take care of the baby and practice and continue practicing KMC even from home. And the fourth one is kangaroo support. What is kangaroo support? It's not just the mother. All the family members should support the mother in initiating and maintaining care for the baby. And always we say that it's not just the mother. All the caregivers can practice kangaroo mother care. There can be kangaroo father care. There can be kangaroo grandfather care. Or every individual who's taking care of the baby can also put the baby onto their chest and give warmth and protect the baby from hypothermia. So the family support is the fourth component of kangaroo mother care. So there is kangaroo position, kangaroo nutrition, kangaroo discharge, and kangaroo support. These are the four components of kangaroo mother care. Now, what are the benefits of giving KMC? Why do we always, whenever a preterm baby is discharged from the hospital, you always insist that the mother to practice KMC from home also? So what are the benefits of using KMC? The benefits are, it helps in increasing the rates of breastfeeding. There is increased breastfeeding, reduced mortality, decreased chances of neonatal sepsis, decreased chances of hospital stay, decreased hypothermia, and there is increased weight gain. Now, what is the best weight at which KMC started? KMC is usually started for babies with a birth weight of less than 1.8 kg. And when can you stop? When the baby reaches 2.5 kg or if the baby reaches terms. Then the baby becomes too large to be kept under this KMC position. So once the baby is term enough, or if the baby has a reached a weight of 2.5 kg, then you can stop practicing KMC. Okay, so that is about KMC. Moving on to the next question. A 26-year-old third gravida mother delivered a male baby weighing 4.2 kg at 37 weeks of gestation through an emergency cesarean section. The child developed respiratory distress soon after birth. He was kept nilperorally and given intravenous fluids. He maintained oxygen saturation on room air. No antibiotics were given. Chest radiograph revealed fluid in the interlobar fissure and the distress settled by 24 hours of life. So what is your likely diagnosis? So if you carefully observe this question, the important points are, it's a term baby. Sorry. The important points are, one, it is a term baby, born via LSCS. Respiratory distress was present soon after birth, but there is no need for antibiotics. SpO2 was normal, settled by itself in 24 hours of life, and the chest X-ray showed fluid in the interlobar fissure. All these points are in favor of the diagnosis of a very self-limited condition which happens in term babies known as TTN, transient tachypnea of newborn. So that is the right answer here. So what is TTN? TTN is the most common cause of distress in term babies. In preterm babies, what is the most common cause of distress? It is hyaline membrane disease or respiratory distress syndrome. So TTN is the most common cause of distress in term babies. And it is higher risk in babies born via LSCS. And it is usually a self-limiting condition. What is the mechanism? The mechanism of TTN is that whenever the baby is born via LSCS, there is no labor. What happens is that there is defective clearance of fluid from the lung. So normally the fluid that is being present in the lung gets cleared out during the process of normal labor. When the cesarean happens, this clearance is not present, and that is responsible for this TTN. So decreased clearance of fluid and secretions from lung in LSCS. It can also happen in normal delivery, but it is always more common in babies born via LSCS. And what can you see on the chest X-ray? There can be fluid in the interlobar fissure. Okay, this is an important MCQ. So most common cause of distress in term babies, LSCS, decreased clearance of fluid, and fluid in the interlobar fissure is a characteristic X-ray feature that you can see. And it is usually a self-limited condition, usually settles by itself in 24 to 48 hours. There is no need for any treatment. Okay, now next question, hyperglycemia in a neonatus. So what is the definition of hyperglycemia in a newborn? Hyperglycemia is defined as a blood glucose of more than 125 milligram per deciliter. 125 milligram per deciliter, if it is more than that, then you call it as neonatal hyperglycemia. Now, what is neonatal hypoglycemia? Neonatal hypoglycemia is if the RBS value is less than 45 milligram per deciliter. Then you can call it as hypoglycemia. How will you manage neonatal hypoglycemia? If the baby is symptomatic, like the baby is throwing a seizure, or if the baby is very lethargic, poor feeding, poor sucking, etc., then you can give 10% dextrose. And what is the dose of 10% dextrose? You give it 2 ml per kg. You give 2 ml per kg of 10% dextrose. What if the baby is asymptomatic? The baby is asymptomatic, then you can try giving feeds and reassess. So if the question is like a baby was brought to your newborn ICU and the routine blood sugar monitoring revealed a GRBS of 40, but the baby is alert and active, what is the management? So even if the GRBS is less than 45, if the baby is asymptomatic, then you can give the feeds and can repeat after 1 hour. But if the baby is having symptomatic hypoglycemia, that is with seizures, poor activity, poor feeding, etc., then you cannot wait. You will have to give intravenous glucose, and what you give is 10% dextrose and the dose is 2 ml per kg. What is the sequelae of hypoglycemia? It mainly causes abnormalities in the occipital cortex and can result in blindness. So that is the problem with neonatal hypoglycemia. You have to aggressively treat it. Okay. Which is the part of the brain that is being affected due to neonatal hypoglycemia? That can be an MCQ. It is always the occipital cortex that is getting affected. Okay. Moving on. What is the mode of heating in this equipment? So what do you see here? This is an incubator, right? So in an incubator, what is the method of heating? It's always convection. So what are the methods of heat loss? Okay, what are the methods of heat loss in a newborn baby? The methods of heat losses, first one is convection. What is convection? Whenever heat is lost from the body to moving air, that is known as convection. For example, if you have a fan that is on, or if there's an open window, what happens? Because of the air column movement, heat is lost from the body. So if you're using an incubator, you can prevent this heat loss due to this moving air. So incubator is used to prevent hypothermia by reducing the mechanism of convection. Okay, so loss of heat from skin to moving air, that is convection. What is conduction? The second method is conduction. That is, if the baby is lying on a cold surface, there is a direct contact with a cold surface, the heat gets lost from the baby to the cold surface. That is conduction. That is, if there is a direct contact with a cold surface. Third one is radiation. Radiation is what happens, the heat dissipates from the body to another cold object that is being placed in the room. So that is known as radiation. That is heat dissipate from skin to a colder object or a surface in the room. Okay. Fourth one is evaporation. Evaporation means what happens if the baby is very wet. What happens? The air, the wet, the water on the baby's body gets converted into the gas and that heat gets lost. So this is the mode of heat loss. It usually happens in the immediately born babies in the labor room when they are wet with the amniotic fluid. So in evaporation, there is conversion of water to gas or air and that heat is lost. That is more common in wet babies in the labor room. So these are the mechanisms of heat loss in a newborn baby. So what are the methods? So we can give an incubator to prevent all this, but there are certain mechanisms the baby do by themselves to prevent this hypothermia. So what is this? The babies do something known as non-shivering thermogenesis. The newborns do something known as non-shivering thermogenesis. And where does this happen? It happens in the brown fat. So in newborn babies, the mechanism of heat prevention of hypothermia is called as non-shivering because shivering is not there. So they do something known as non-shivering thermogenesis and that happens in the brown fat. Okay, that is the mechanism. Now, what is the normal temperature of a newborn? The normal temperature of newborn is between 36.5 to 37.5 degrees Celsius. What is cold stress? The temperature is 36.4 degrees Celsius. It is known as cold stress. If the baby is in cold stress, then it is a risk factor that the baby may soon go in for hypothermia. So how do you know whether the baby is in cold stress? You touch that extremities, the palms and the soles of the baby, and then you touch the trunk. If both the trunk and the palms and soles both are warm, then it is known as baby is warm. There is no homothermia. If the palms and soles are cold, but the trunk is warm, then it is known as cold stress. If the palms and soles and the trunk both are cold, then it is hypothermia. So the temperature equivalent of cold stress is 36.4. Now, what is hypothermia? If the temperature falls below 36.4, then it is known as hypothermia. And this can again be classified into mild, moderate, and severe. What is mild? If it is between 36 to 36.4. Moderate is 32 to 36. Severe 30 than 32. So they may ask a question like, what is the definition of severe hypothermia? It is less than 32 degrees Celsius. And what is cold stress? This is 36.4 degrees Celsius. Important MCQ point. Now, what is the recommended temperature of the nursery? The recommended nursery room temperature is 22 to 26 degrees Celsius. If they ask us a one-liner, then you give the answer as 26. That is the recommended temperature of the nursery. Then there was another previously asked question about thermoneutral environment. Thermoneutral environment. What is thermoneutral environment? Thermoneutral environment is the range of environmental temperature at which the basal metabolic rate of the baby is minimum. That is, the temperature, the ambient temperature is such that the baby does not have to spend any more energy in maintaining normothermia. So that is the most suitable temperature for the baby to exist. That is known as the thermoneutral environment. So that is the range of environmental temperature at which the basal metabolic rate of the baby is minimum. That is known as thermoneutral environment. This is also a previously asked MCQ. Okay. Now, a newborn loses maximum heat from which part of the body? So, heat loss is always maximum in areas with maximum surface area. So, heat loss will be seen in areas with maximum surface area, and the part of the body with maximum surface area in a newborn baby is the head. So, maximum heat loss is from the head. That is why whenever you are advising about a mother, about warm care of the baby, you always advise them to cover the head with a cap. If it's a preterm baby, you make sure that the head is covered with the cap so that heat loss from the head can be prevented, because that is a major site of loss of heat. Okay, so that is why cap and mittens are very important. Now, next question is about Apgar score. If Apgar score is 6 at 5 minutes of life, then what is the interpretation? So, Apgar scoring again is very important from an MCQ point of view. So, what does Apgar stands for? So, let's look at that first. Apgar stands for, you can remember at APGAR itself. So, A, P, G, A, R. A for appearance. P for pulse rate. G for grimace. A for activity. And last is R for respiration. And the scoring is like 0, 1 and 2. So what of the appearance? The appearance of the baby, if the baby is pink in color, then pink in color, then it is good. Then you give the score as 2. What is if the baby is having, the body is pink but the extremities are blue? That is known as acrocyanosis. Then you give the score as 1. Acrocyanosis. That is only the extremities are blue, but the body is pink in color. If the whole baby is blue in color or cyanos, then the score is 0. That's a very bad thing, right? Then pulse rate. Pulse rate, if it is more than 100, it is 2. If it is less than 100, it is score 1. If there is no pulse or heart rate is not heard, then it is 0. Then grimace is also known as reflex activity. If you stimulate the baby, what is the activity of the child? If it's a healthy baby, there will be active movements will be present. If it's a score 1, if there is only some flexion, there is some flexion movement is there, but it's not very active. If there is no activity, sorry, grimace is reflex activity. So if you give stimulations, if the active movement is present, then it is score 2. If only grimace, that is only the baby gives a small response like a grimace, then it is score 1. If there is no response, then it is score 0. Then activity of the bride, if the baby is vigorously active, you give it a score 2. Only some flexion, score 1. If there is no activity, there is no movement at all, score 0. Respiration, if there is good cry is present, score 2. Slow, irregular breathing only, then you give score 1. If there is no breathing, it is score 0. So, appearance, blue, trunk is pink, extremities are blue in color, it is score 1. If the whole baby is pink in color, 2. Pulse rate, absent, 0, less than 100, then it is 1, more than 100, it is 2. Then grimace, reflex active, stimulate the baby, there is no response, then it is 0. Only grimacing is present, then it is score 1. If the baby shows active movement, then it is score 2. Then you have activity of the child. If the baby is having no activity at all, then it is 0 score. Only some flexion is there, then it is score 1. If vigorous activity is there, you give it a score 2. And finally, respiration. If there is absent respiratory movements, it is so score is given as 0. If there is slow and irregular breathing efforts are present, then it is score 1. The baby is having a good cry and good breathing movements, then you can give it a score of 2. How do you interpret Apgar score? If the score is between 0 to 3, it is severe birth asphyxia. If it is 4 to 7, it is moderate. If it is less than, if it is more than 7, it is normal. It is not less than 7, it is more than 7, it is normal. Okay, so when is Apgar score done? Apgar score is done at, it's not done at birth. It is done at 1 minute, 5 minutes, and at 10 minutes. So Apgar scoring is not done soon after birth. It is done at the end of 1 minute. So even if the baby didn't cry soon after birth, if you do the initial steps of resuscitation, including PPV correctly, and if at the end of 1 minute the baby is having a good neurological status as evidenced by a good Apgar score, then the baby has less chance of developing hypoxic ischemic encephalopathy and various other sequelae. So that is why the initial steps of NRP is very important, because Apgar scoring is done at the end of 1 minute and not soon after birth. So you have 1 minute time to give resuscitation to the baby. Okay. That is that. Okay, moving on to the next question. What is the interpretation of an Apgar score of 3? So, if the Apgar score is 3, what is the interpretation? So, we have already looked at the table, right? If the Apgar score of the baby, one second. If the Apgar score of the baby is less than 3, then it means that the baby is a severely depressed baby. So, that is the right answer, the severely depressed baby. Moving on to the next question. So, that is about the Apgar score. I hope it is clear. Now, moving about jitteriness. So, jitteriness can be distinguished from seizures by. So, what is jitteriness? So, jitteriness is basically a shivering like movements, but it is not seizures. So, how do you differentiate jitteriness from seizures? You can look at this table and answer that. So, jitteriness, what is ocular deviation? So, if there's a seizure, you can say a particular gaze of the baby will be present. The baby might be having an upward gaze or a fixed gaze towards certain direction. So that is seen only in seizures. In jitteriness, that ocular deviation is not seen. So ocular deviation is seen only in seizure. Stimulus sensitive. That is, if the baby is moving this limbs in the case of jitteriness, if you restrain this, if you hold that limb, then that movement will stop. So it will stop with passive movement of the limb, whereas in seizures it is not, it will not stop with that passive movement. Excuse me. Then the last one is autonomic changes. If the baby is having seizures, it will be associated with tachycardia. Whereas if it is a mere jitteriness, there will not be any autonomic changes like tachycardia. So autonomic changes will be seen in seizures, but it will not be seen in jitteriness. So these are the three methods by which you can differentiate jitteriness from seizures. So seizures is a pathological thing. Jitteriness is not as pathological as seizures. So the three differentiating points is one, ocular deviation will not be present. Jitteriness can be restrained with passive movement, and jitteriness is not associated with any autonomic changes. Okay. And what is the most common cause of jitteriness in a newborn baby? Most common cause is hypocalcemia. The most common cause of jitteriness is hypocalcemia. Okay. Now, a few important points about neonatal seizures. We have already discussed neonatal seizures in a previous class, but just a few important points that I want to mention here is, what is the most common type of neonatal seizures? The most common type of neonatal seizures is subtle seizures. And what is the most common cause of neonatal seizures? HIE, hypoxic ischemic encephalopathy, is the most common cause of neonatal seizure. Which is the seizure with best prognosis? The best prognosis is focal clonic seizures. And which is the one with worst prognosis? Myoclonic seizures. These are certain one-liners. And which is the drug of choice for neonatal seizures? Phenobarbital. That is given as the first line of drug. So these are certain important one-liners about neonatal seizures. Now we'll take a short break, and after that we'll get back to you. Welcome back. So that was about jitteriness and neonatal seizures. Now moving on to the next question. The soul of a newborn baby as shown below is suggestive of. So what is this? You're looking at the soul of the baby and you have to guess whether the baby is a term baby or a preterm baby. So that scoring system is known as New Ballard scoring system. So that is again another important area. The New Ballard scoring system, NBS. So the scoring system, the name of the scoring system with which you can differentiate whether it's a term baby or a preterm baby is New Ballard scoring. Why is it important? Because if you have a baby, the baby is born. According to the mother's date, the baby, it might be stated as a term baby. But if you look at the baby is not looking as a term baby. So you can approximately calculate the gestational age of the baby by looking at certain phenotypical manifestation. By looking at a head to foot examination of the baby, you can assume the gestational age of the baby. And that scoring system is known as New Ballard scoring. Okay. So New Ballard scoring includes two important parts. It includes a neuromuscular grading and a physical maturity. So we have neuromuscular maturity and physical maturity. And neuromuscular maturity includes various measures. What are they? The posture of the child, square window. Square window, what they do is that they look at the angle. at the wrist. That is a square window. It is looked at the wrist joint. Then you have arm recoil, popliteal angle, scarf sign, and heel to ear. Okay, of which is the least sensitive? The least sensitive is arm recoil. The arm recoil is the least sensitive one. Okay. Okay. Now, about the physical maturity, you have other methods. That is the skin. You can look at how is the skin, the lanugo hair, plantar surface. That is the sole of the foot. That is what they have asked in this question. Breast, ear, genitals, and of the males and that of the females. The plantar surface, what you look is that you look at the creases. In a preterm baby, there will only be creases in the anterior part, but if there is a creases extending through the entire length of the foot, then you can call it as a term baby. If the creases are present only in the initial anterior part only, then you have to look at the sole of that baby. What can you assume? Here, you as you can see that there is only creases in the anterior part. Posterior part, there are no creases. So, it means that the baby is a premature baby. So, you need not know the entire scoring system, but you have to know some of the salient points. Now, let's look at what are the salient points are. So, posture of the baby, if the baby is in a well flexed posture, if there is flexion is present, then it means that the baby is more towards term. If flexion is poor, then means it is a preterm baby. Square window, if more the term baby, the less will be the angle. Okay, if the baby is a more term baby, the angle will be very less. If it's a preterm baby, the angle will be much higher. That is, you won't be able to completely flex if it's a very preterm baby. Then arm recoil is not a very sensitive measure, but the measure you have to know is a scarf sign, because scarf sign can be asked as a pictorial question for you. So what they do is that you pull the one hand towards the opposite side like this and see how much does the elbow crosses. If the elbow crosses completely like this, then it means that the flexibility of the joint is more and more likely that the baby is a premature baby. But if you're not able to completely cross the hands across, like in the case of us, we are not able to cross the hands across the midline. If you're not able to cross, then it means that it is a term baby. So if you're not able to cross, then it means that it is term. If you are able to cross, then it means that it is a premature baby. Okay, not able to cross means preterm. If you are able to cross, if you are not able to cross, means it is a term baby. If you are able to cross, then it means it's a preterm baby. So that is about the scarf sign. It's an important part of the neuromuscular maturity. Now, among the physical maturity, the most important one that you have to know is the plantar surface. That is, if there are creases over the entire sole, then it is a term baby. If the creases are very less, then it is a preterm baby. Less creases means it is a premature baby. Okay, you need not waste your time by hearting the entire thing. Just nobody will ask you to score a baby, but they may ask you if the scarf sign is like this, what will be the gestation age, whether it's a premature baby or a mature baby. Like that, they might ask you. So for that only, I have put this chart here. Then the other important thing you have to see from this table that is given here is the minimum score is what? The minimum score is -10 and the maximum score is 50. So the minimum score -10 corresponds to a baby of gestational age of 20 weeks. So the minimum score is -10 and it corresponds to 20 weeks of gestation. And the maximum score is 50 and it corresponds to 44 weeks. So they can ask what is the up to what gestation age you can calculate from a Newbillard scoring. It is from 20 weeks to 44 weeks. -10 to +50. Okay, -10 to +50. That is important. And what is the lowest score? The lowest score is -2. And for what you give this -2? That is given for plantar surface and for the eye and ear. And the maximum score is +5 and that are given to the popliteal angle and skin. Okay, so my maximum low score is -2 and the maximum score that you given for a single particular parameter is +5. Okay. So that is about the new Ballard scoring. Now this is about prematurity. So if you want to know whether the baby is a premature or not, you can use this new Ballard score. What if the baby is post-term? What are the features of a post-term baby? Post-term baby means a baby who is past 42 weeks. What are the features that you can see? You can see that there will be peeling of the skin. You can see skin peeling. Then the umbilical cord color will be green in color. Then you can see nails will be green in color. Why? Because they can have premature or they can have meconium stained amniotic fluid. In a postterm babies, they are at higher risk of passing the meconium in utero, and because of this passage of meconium in utero, they can have green colored umbilical cord and green color nails. And the entire baby might be having something known as old man appearance because of the wrinkled skin and the skin peeling. They may have an appearance known as old man appearance. Okay, so that is how you differentiate a postterm baby from a term baby. The scoring system, the name is New Ballard scoring. Okay, so that's about that. So which sign is being elicited in the image below? So what is the sign? We are pulling the one limb beyond the midline. So what you can see that if this sign, the name of the sign is scarf sign. So if they cross the midline, then it means that the baby is a premature baby. If it do not cross, then it is a term baby. Okay, so this is a important sign which is a part of New Ballard scoring, that is known as scarf sign. Okay, moving on to the next question. Ponderal index. What is the formula for calculating ponderal index? The ponderal index, the formula is weight in kg divided by height cube into 100. So why do you calculate ponderal index? You have to differentiate between symmetrical and asymmetrical IUGR. So what are the two types of IUGR? IUGR can be of two types. Can have symmetrical IUGR and asymmetrical IUGR. Now, what is symmetrical IUGR and what does it mean? Symmetrical IUGR means the whole body, that is the head, the trunk, the limbs, every part of the body gets shrunken symmetrically. And when does this happen? Symmetrical IUGR usually happens when the insult to the baby happens during the early pregnancy or early gestation. And that is usually because of some diseases or defects pertaining to the baby itself, like some chromosomal disorder, some genetic disorders, etc. If the baby is having, the baby may fail to grow as normally as a normal baby. So that is the features of symmetrical IUGR. So when does the insult happen in symmetrical IUGR? The insult happens in the early gestation, meaning can either be in the first or early second trimester. And it is usually due to fetal causes like genetic or chromosome defects. Or it can also be because of certain intrauterine infections like torch infections. Can also cause symmetrical IUGR. And what happens? The head circumference, the weight, the length, everything gets shortened. Now, what about asymmetrical IUGR? In asymmetrical IUGR, what happens? The insult happens late in the gestation, that is, in the later part of second trimester or the third trimester. And usually it is because of certain maternal causes, like mother is having some preeclampsia, resulting in uteroplacental insufficiency, and that causes fetal growth restriction. So, in that case, there is a phenomenon happening known as brain sparing effect. That is, the blood supply to the brain becomes relatively conserved, but the blood supply to the rest part of the body will be greatly compromised. So what happens? The head size remains the same, but the other part of the body becomes small. So the head circumference will not be affected, but the length and the weight of the body will be affected. That is the asymmetry. That is why it is known as asymmetrical IUGR. And asymmetrical IUGR has got a better prognosis than symmetrical IUGR. So here the insult happens in the late third or late second or third trimester. Okay. And what is the cause? It is usually maternal cause, like anemia in the mother, preeclampsia, causing uteroplacental insufficiency. So what will be the head circumference? The head circumference will be normal, but the weight and the length will be decreased. This is known as brain sparing effect. So this has got a good prognosis, whereas symmetrical IUGR has got a bad prognosis. And what will be the ponderal index? It will be more than 2 if it is a symmetrical IUGR, and it will be less than 2 if it is a asymmetrical IUGR. So that is the importance of calculating ponderal index. It is weight divided by height in cube into 100, and if it is more than 2 it is symmetrical IUGR, it is less than 2 means it is asymmetrical IUGR. Okay, so these are the important points about ponderal index and its clinical application. Moving on to the next one, very low birth babies are. So babies can be divided into low birth weight babies, very low birth weight babies and extremely low birth weight babies. So how was this classification? If the birth weight is less than 2.5 kg, it is LBW, that is low birth weight. If it is between 2.5 to 1.5, then it is, that is less than 1.5 kg, then you call it as very low birth weight baby. And if it is less than 1 kg, it is extremely low birth. Okay, so that is the definition of different types of low birth weight. So what is SGA? SGA is if the weight of the baby is less than 10th centile. What is LGA? If the birth weight of the child is more than 90th centile. And what is AGA? Appropriate for gestational age. If it is between 10th to 90th. If it is between 10th to 90th centile, then it is normal, appropriate for gestational age. SGA means small for gestational age. LGA means large for gestational age. Okay, that is that. Moving on to the next one. An orthopedician adducts the flexed hip and gently pushes the thigh posteriorly in an effort to dislocate the femoral head of a neonate. What is this maneuver called? So, this is known as Barlow test. So basically, in order to see whether if the baby is having a CDH or DDH, what is developmental dysplasia of the hip. For the diagnosis of DDH, there are two tests that we employ. One is Barlow and the next one is Ortolani test. So here the Barlow test and Ortolani test, what we are doing is that in Barlow test, what you're doing is that you are trying to dislocate the hip. If the baby is having not, the hip is present, the femoral head is in the acetabulum, but if it's a dislocatable hip, that is, if the hip is unstable, if you perform this Barlow maneuver, the hip gets dislocated. Okay, normal children, even if you perform this Barlow, the hip will not dislocate. But if it is a dislocatable hip, then if you perform the Barlow's maneuver, then the hip will dislocate. So Barlow's, you can study it as B for bad. That is, Barlow is for you are dislocating the hip. Or you can also remember as Barlow as Bahar low. Bahar means out. You are pushing it out. So you are dislocating the hip. Okay. Ortolani, what you are doing? You are relocating the hip. In ortolani, what you do is that already the hip is dislocated. If you are relocating the hip, then it is not as ortolani manner. So in Barlow, you have to abduct. So what are you doing? In Barlow's manner, you are trying to dislocate. So you have to adduct and push posteriorly so that the hip gets dislocated. In the case of ortolani, what you're doing is that you abduct the hip and you push it anteriorly so that you are relocating. So Barlow's is bad, it is dislocating the hip. Ortolani is good, you are relocating. So that is how you can remember, and both these tests are used for the diagnosis of developmental dysplasia of the hip or DDH. Okay. Now, true about cephalhematoma. So there are two types of scalp swellings that you have to know about. One is cephalhematoma, the other one is caput succedaneum. So what are the differences between the two? Caput and cephalhematoma. So what is the most important feature? What is getting collected? In the case of caput, what is getting connected is just the edema fluid. Whereas in the case of cephalhematoma, it is blood. And which is the plane in which it is getting collected? Caput, it is getting collected in the subcutaneous plane. Whereas cephalhematoma, it occurs in the subperiosteum. Since cephalhematoma, it happening in the subperiosteal plane, it is always limited by suture lines. It will not cross suture lines. Do not cross sutures. Whereas caput, since the subcutaneous plane, it can easily cross suture lines. And when does it appear? Caput usually appears a few hours after birth. Whereas cephalhematoma appears after 3 to 5 days. And when does caput resolve? Caput usually resolves in 3 days. Whereas cephalhematoma resolution may take up to 3 to 6 weeks. And since it is blood getting collected, there is increased chance of neonatal jaundice. Because this collected blood can undergo hemolysis and there is increased risk of developing neonatal jaundice. So this is the differentiating points between caput succedaneum and cephalhematoma. So what is true? Cephalhematoma, is it limited by sutures? Yes, cephalhematoma is limited by sutures. It is caused due to periosteal injury? No. It occurs due to fluid accumulation? No. What is getting accumulated? It is blood. Regression in 24 hours? No, it usually takes 3 to 6 weeks for regression. So the right option is option number A, that is, it is limited by sutures. Okay. Now, next one is about the most common newborn rash which presents at 24 to 48 hours of life is. The answer is erythema toxicum, that is erythematous papular pustular lesions, and the name of that lesion is erythema toxicum. So erythema toxicum. So we have to know about some of the normal benign findings in a newborns. Normal benign skin findings in newborns. Benign skin changes in newborn. So the most important or the most common type of skin change that a newborn that can happen in newborn is erythema toxicum. And it is basically appears when the red color papulomacular lesions appear on the face, the trunk and everything. Usually develops after 24 hours of life, that is appears at 24 to 48 hours. And it always show a relapsing. It comes on and off. It comes, then it fades away, then it again comes. Okay, it usually happens on and off. And it does not require any treatment. It's a self-limited condition. And what does this lesions contains? These lesions on microscopy contains eosinophil. So E for eosinophils. contains eosinophils. The second most common is white color small papilla lesions that you can see over the nose and here over the forehead region. That is known as milia. That is also normal. Then in the hard palate also you can see certain white color dots. That is known as Epstein pearls. Usually seen over the hard palate. That is also normal. Then you have something known as neonatal pustular melanosis. Neonatal pustular melanosis. Here it is again a maculopapular rash but without erythema. This rash is similar to erythema toxicum but without erythema. And what does it contain? Erythema toxicum, the rash contains eosinophils. Here the content is neutrophils. So you can remember as N for neutrophils. Erythema toxicum, it is E for eosinophils. Here neonatal pustular, N for neutrophils. The likewise you can remember. Then last one, then next one is Mongolian spot. These are usually bluish green patches that you see over the lower trunk, back of lower trunk, and it usually disappears by 1.5 years of age. Then there is something known as harlequin color change. What is harlequin color change? Here, if there's a midline, across the midline, one half of the body will be showing normal, the other part will be showing a pigmentary or reddish discoloration. It is self-limited, transient, and subsides on its own. And then finally, you can see a stork bite or salmon patch. It's a small reddish color discoloration usually seen on the forehead and over the upper eyelids that also disappears by its own. Upper eyelid and forehead. It also disappears on its own. So these are the various benign skin changes that can happen in a newborn. Okay. Now, how much time later should ROP screening? So here they are asking about ROP screening. Done for a 2-week-old baby being treated in the NICU who was born at 28 weeks of gestation. So when is ROP screening done? The ROP screening is done. Why? Because premature babies, if they're exposed to high oxygen, that is high oxygen concentration, they have a high risk of developing an injury to the retina, and that condition is known as retinopathy of prematurity or ROP. Retinopathy of prematurity. And who is at risk of developing this? Premature babies. The risk factors are prematurity and exposure to high oxygen concentration. So that is why the target SpO2 for all premature babies to prevent ROP, the target SpO2 is 91 to 94%. You need not give excess oxygen. The oxygen should be provided in such a way that the SpO2 is maintained between 91 to 94%, because if you give excess oxygen, they can develop something known as ROP. So when do you do ROP screening? ROP screening is normally done at 4 weeks of gestation. No, not 4 weeks of gestation, at 4 weeks of life. Postnatal age. Or 32 weeks post-menstrual age. It is done at 4 weeks of postnatal age or 32 weeks of post-menstrual age, whichever is later. So here the baby is born at 28 weeks of gestation and the baby is already 2 weeks old. So normally the ROP screening is done at 4 weeks of age. Now since the baby is already 2 weeks old, now when do you have to do the ROP screening? It has to be done after 2 weeks, such that the age of the baby at that time will be around 4 weeks. So this question is a bit tricky. If you just answer it blindly thinking ROP screening is always done at 4 weeks, you will get it wrong. The baby is already 2 weeks old. So now we have to do it after 2 weeks. So that the age of the child at that point is 4 weeks of age. So here in this question, the right option is option A, that is 2 weeks. Okay. Now that is that. Now moving on to the next part, that is we have finished newborn. The important points which we have left out, we have covered in this live session. The other important areas we have already dealt with in the previous live. Now, since the newborn part is completed, now we'll quickly look at some of the important points in anthropometry and nutrition. The major parts about SAM, nutrition, anthropometric measures have already been dealt in our previous class. So here it's just a catch up of some of the points which we have missed in the previous class. Okay. So, anthropometry and nutrition. A 16-month-old boy whose weight is 8 kg. So, the baby's age is 16 months. Okay. The age of the baby is 16 months and the weight is 8 kg. Was brought to the clinic by his mother. And the image of the chart is given. So, what is your next step and how do you advise the baby? So, the age is 16 months and the weight is 8 kg. So what is the expected weight of the child at 16 months of age? The expected weight is at 2x plus 8. That is a formula for calculating the expected weight. So that will come around 10 kg. Around 10 kg. So here the baby is having only 8 kg. Okay. So the baby is having, it's around 11 kg, not 10 kg. The expected weight is around 11 kg. So, if you look at the weight of the baby is only 8 kg. So, what is the percentage? The percentage is 8 divided by 11 into 100. It will come to around 75%. So, according to the IAP classification, it comes under protein energy malnutrition grade 1. And if you plot in the chart also, it comes under the area of the yellow zone. It will come under the, if you look at the ICDS chart, it will come under the yellow zone. That is, the baby is having moderate malnutrition. The baby is having moderate malnutrition. What do? You give dietary advice to the baby. You give dietary advice to the mother to give the child more calorie dense food. So, the baby is moderately malnourished and advise the mother to give more calorie dense food. So, that will be the right option. Okay. Now, moving on to the next question. At what age does the child attain half of the adult height? Okay. So, when does the baby attain half of the adult height? So, the adult height, half of the adult height is attained in boys by 2 years of age. In girls, half of the adult height is attained by around 19 months of age. So, if you look at the options, the fitting option is 18 to 24 months. That will be a sum up of both the boys and the girls. So, the right option here is 18 to 24 months. And by 2 years, what happens to the brain growth? The brain growth by 2 years, around 90% of the brain growth will be completed. That is another important MCQ that has been asked. So, by 2 years, the height becomes 50% of the adult height. But what happens to the brain growth? The brain growth is around 90% of that is seen in the normal adult. Okay. Now, this is another chart that we have already discussed previously. Here, we are looking at what happens to the birth weight at each age. So, at 5 months, the birth weight doubles. At 1 year, the birth weight triples. At 2 years, the birth weight becomes 4 times. At 3 years, the birth weight becomes 5 times. Okay. Now, what are the formulas for calculating the birth weight, the expected weight in each of these age groups? In 3 to 12 months, the formula that we use is x plus 9 by 2. In 1 to 6 years, the formula that we use is 2x plus 8. In 7 to 12 years, the formula that is used is 7x minus 5 divided by 2. So, this is the formula with which you can calculate the expected weight at a particular age, where x stands for the age in years. Okay. Then height with respect to age. At birth, the height is 50 centimeter. The normal length or the height at birth is 50 centimeter. By 1 year, it becomes 75. That is 25 centimeter is gained in one first year of life. That is maximum height velocity happens in 1 year of life. 75 centimeter. Then by 2 years it becomes 90 centimeter, and by 4 years it becomes 100 centimeter. That is, height doubles at 4 years. The height of the child becomes double the height at, that is 50 becomes 100 at 4 years of age, and 50% of adult height it reached at 2 years of age. Okay, so that is some of the important MCQs about anthropometry. Now, next is, which of the following is not a criterion for severe acute malnutrition? So, how do you define severe acute malnutrition? SAM. The definition of SAM is there are two types of definition. That is, if the child is between 6 to 59 months. That is from 6 months to 5 years of age. 59 months means 5 years. So 6 to 59 months, the definitions is, one is MUAC, mid upper arm circumference less than 11.5 centimeters. Or if the weight for height, you are always, please ensure the criteria that we are using here is weight for height is less than -3 standard deviation, or presence of bipedal edema. So, if the age of the child is between 6 to 59 months, that is 6 months to 5 years, we have three criteria. Either MUAC is less than 11.5, or the weight for height is less than -3 standard deviation, or if the child is having bipedal edema. If any one is present, it's not or and, any one if present, you can diagnose it as severe acute malnutrition. Okay, what if the age of the child is less than 6 months? If the age of the child is less than 6 months, you cannot use MUAC, because MUAC is an anthropometric measure. It is used only for children above 6 months of age. So if a child is less than 6 months of age, the MUAC cannot be used. But instead, what you use is visible severe wasting. If on looking on visual inspection, if the baby is having severe visible wasting, then it can be taken as one of the parameters to diagnose SAM. The other two is the same, or you can use weight for height less than -3 standard deviation or bipedal edema. That two remains the same, but since MUAC cannot be used, instead of MUAC, what you use is severe visible wasting. And how do you look for edema in SAM? You look always at the dorsum of foot, or if it's a recumbent child, then you can look at the sacrum. If the baby is always lying down, the dependent area is the sacrum. If the baby is walking around, the dependent area is foot. So depending on that, you can either look at the dorsum of the foot, or you can look at the sacral area, and you press for how long? 10 seconds. And if there is pitting edema is present, which is bilateral, you can call it as SAM. And SAM can again be of two types. It can be kwashiorkor or marasmus. If there is edema, it is kwashiorkor. If there is no edema but the other criteria are fitting, then you call it as marasmus. About the features of kwashiorkor and marasmus, please go back to the previous live we have already done. The features, the clinical features and the management of SAM, especially kwashiorkor and marasmus, extremely important for your MCQ point of view. So please go and read about that. Okay, so that is about the criteria for SAM. So they have asked which is not a criterion. So let's look at each of these options. Mid upper arm circumference less than 11.5, yes. Weight for age less than -3, or weight for height. Weight for height is used, but weight for age is not used. Weight for age is not used. Weight for height is used as a criterion, bipedal edema. So the right option is the wrong, of the following, the one which is not used as a criterion is weight for age less than -3 standard deviation. Okay, now here in this table, there are certain indicators and WHO classification. Please go through this, it is important. Okay. Now, before moving into the vaccination, let's take a lunch break, and after that, we'll come back to the vaccination. let's move on to our next topic, that is vaccines. So the first question here is, pentavalent vaccine and MR vaccine vials were open, okay, and cold chain was maintained. What will you do with these open vial vaccines? So here they have asked about an important new topic, that is open vial policy. It's a new important scheme that has been brought forward by the government. So that is something known as open vial policy. What is this open vial policy? Open vial policy, it allows the reuse of vaccines. That is, if a vaccine vial is opened, if you're not able to completely use that particular vial, you can use that vial provided the cold chain is maintained for a period of up to 4 weeks. So that is, it allows reuse of partially used multi dose vials. For how long? Up to 4 weeks or 28 days, provided the cold chain is maintained. That is the most important step. You have to maintain the cold chain. Okay, otherwise the vaccine will not be fit for use. Now, which are the vaccines for which this open vial policy can be used and for which vaccines cannot be used? So, it can be used for, or it can be applicable for the following vaccines. What are they? DPT, TT, OPV, hepatitis B, pentavalent vaccine with Hib, and also IPV. For these 6 vaccines, the open vial policy is applicable. So, what are the vaccines for which we cannot use the open vial? The open vial policy not used for or cannot be used for measles, BCG vaccine, rotavirus vaccine, and JE vaccines. For these vaccines, the open vial policy cannot be applicable. Is not applicable. You cannot use the open vial vials. If you open the vial, you have to use it and then discard. So here they ask, we have opened the vial and how do you want to go about? So they write out discard both. So they have opened a pentavac and an MR vaccine. So according to the open vial policy, pentavalent vaccine can be kept provided cold chain is mainly, but MR vaccine we cannot reuse. So the right option is discard the MR vaccine and use the pentavalent vaccine. So the right option is option number C. Moving on, all our new vaccines included in the national immunization schedule except. So we have a recent revision of the national immunization schedule and a variety of new vaccines have been added. So let's look at what is the revised national immunization schedule that is given in this picture. And this is the immunization schedule that is being followed in our country from 1st of January 2023 onwards. So at birth, we have at birth, what are the vaccines? You have OPV, BCG, hepatitis B. At 6 weeks, which are the vaccines? You have OPV, you have rotavirus vaccine, you have fractional IPV. In government, what you're giving is fractional IPV. Fractional IPV means 1/5 of the total IPV use. That is fractional IPV. And then you have pentavalent. And then you have the PCV1. At 10 weeks, all these vaccines except which are the vaccines which are not given at 10 weeks. At 10 weeks vaccination, you have OPV, RVV and Penta. PCV and fractional IPV is not given. 14th week vaccine is same as that of what we give at 6 weeks vaccine. At 9 months, you have MR vaccine. It is not MMR. Now we are giving only MR vaccine. Then you have fractional IPV booster dose, PCV booster, and JE vaccine is given in certain endemic areas. Not in every areas, but in endemic areas, JE vaccine is given. Then at 16 to 24 months, you have OPV booster, MR second dose, that is measles rubella second dose. Then you have DPT booster and JE second dose. And at 5 to 6 years, you have a DPT booster. And 10 years, you have TD vaccine. 16 years, you have TD vaccine. And pregnancy, we'll deal with it later. So pregnancy, let be there. So this is the normal national immunization schedule, vaccination schedule. So they have asked which vaccine is not included. Rotavirus is included. Adult GE vaccine is included. MR vaccine is included. But influenza vaccine is not included in the national immunization schedule. Now, how would you like to give vaccination to a pregnant woman? Pregnant woman is given 2 doses of TD vaccine. First dose is given as soon as the mother has got pregnant, and the second vaccine is given 4 weeks after the first dose. So you give 2 doses. And how long? 4 weeks apart. Now, if the mother becomes pregnant again within 3 years, if second pregnancy happens in less than 3 years after the first pregnancy, then and provided that in the first pregnancy the mother had already taken 2 doses of TD vaccine, then only 1 dose is required. Okay, that is about the national immunization schedule. Now, a little bit one-liners, important one-liners. What is the dose of BCG vaccine? The dose of BCG vaccine is generally 0.1 ml. But if the age of the child is less than 1 month, then the dose is 0.05 ml. Now, the route of administration of vaccines are also important. So, which are the vaccines which are given as orally? Rotavirus vaccine, OPV vaccine, and vitamin A. Vitamin A is given to the children from 9 months onwards along with MR vaccine, and after that you give it every 6 monthly till the child turns 5 years of age. So that is how vitamin A is given, and that is also given perorally. Then, which are the vaccines which are given as intradermal? BCG is given intradermally and fractional IPV is given intradermally. Fractional IPV is given intradermally, but IPV, the full dose IPV is always given as intramuscular dose. Okay. IPV is intramuscular, fractional IPV is intradermal. Then, which are the vaccines which are subcutaneous? Measles vaccine is given as subcutaneous route. Then, JE vaccine. JE vaccine is given as subcutaneously. Varicella vaccine is also given as subcutaneous. All other vaccines are intramuscular. All other vaccines are given as an intramuscular dose. So these are the various routes of administration of vaccines. Okay. Now, one single point that I want to say is about something known as Mission Indradhanush. What is Mission Indradhanush? Mission Indradhanush is a program that has been put forward by the government in order to make the population immune against 7 illnesses. There are vaccination against 7 illnesses are made mandatory, and we ensure that all the children get vaccination against these 7 illnesses. So that is called 7 illnesses, like the 7 colors of the rainbow. Hence it is known as Mission Indradhanush. So which are these 7 diseases? One is diphtheria. Second is whooping cough or pertussis. Tetanus, that is DPT. Diphtheria, pertussis, tetanus, polio, TB, measles, hepatitis B. So these are the 7 illnesses which is covered under the umbrella of Mission Indradhanush. Okay, so that is that. Now moving on to the next question. An 8-month-old child had a history of unusual crying, altered sensorium and convulsions following the previous vaccination, which included BCG, DPT, OPV and hepatitis B. Now parents have brought the child for next dose of vaccination. So which vaccine should be given with precaution? So the question is, which vaccination is to be given with precaution? So here the vaccine which is responsible for the above mentioned side effects, that is fever, seizures, convulsions, altered sensorium, is DPT vaccine. So the DPT vaccine is considered to be having certain side effects. Which are the common side effects of DPT vaccine? The side effects of DPT vaccine, the known side effects of DPT vaccine is, first one is inconsolable cry for more than 3 hours. The baby keeps on crying for more than 3 hours. These are the side effects of DPT vaccine. Then there is hyperpyrexia within 48 hours. The child will have very high fever. Then there is something known as hypotensive hyporesponsive syndrome, HHS. Hypotensive hyporesponsive syndrome usually happens within 48 hours. And seizures within 72 hours. All these are some of the very known side effects of DPT vaccine. Okay, but these are not contraindications. But even if the baby develops these are not contraindications for giving the next dose of vaccination. The only thing that you have to do is take precaution. What are the precautions? You can give prophylactic antipyretics. If the baby had previous episode of seizure, you may even advise them to get admitted for the next dose of vaccination, that after getting the vaccine, they can get admitted for a period of 24 hours or 48 hours. And after that, no seizures, and the baby can be very confidently discharged home. So, the episode of any seizure, hypotensive hyperresponsive episode, inconsolable cry, or hyperpyrexia, and all these are known side effects, but none of them are contraindications for giving DPT vaccination. Then what is the contraindication of giving DPT vaccine? When do you say that DPT vaccine is contraindicated? The absolute contraindication for giving DPT vaccine are only two in number. One is if the child developed an anaphylactic reaction to the previous dose. The baby developed any anaphylaxis to the previous dose of vaccination. That is one. And second one is if the baby has developed encephalopathy within 7 days of vaccine administration. That is, after giving the DPT vaccine, the baby developed encephalopathy. So encephalopathy within 7 days of vaccination. These are considered as absolute contraindication for giving DPT vaccine. Then there is one relative contraindication. The relative contraindication of the child is having any progressive neurological disease or a neurodegenerative diseases, the first dose of DPT vaccine should be given with caution. So, relative contraindication is progressive neurological disease. Then the first dose may be considered with caution. So that is the only relative contraindication towards BPT vaccines, and all these side effects are mainly because of the pertussis component of the vaccine. Okay, so that is about DPT vaccine. Now, most heat sensitive vaccine is. Now here this question is about the heat sensitivity towards vaccines. So let's look at what are the heat sensitive vaccines and which are the freeze sensitive vaccines. So the heat and light sensitive vaccines. Heat and light sensitive vaccines. What are they? The heat and light sensitive vaccines are OPV. OPV is the most heat sensitive vaccine. Then you have MR vaccine, measles rubella vaccine, and then you have the BCG, RVV, that is rotavirus and GE. So OPV, MR, BCG, rotavirus and GE vaccine. All these vaccines are heat and light sensitive. Of which is the most heat sensitive? The right answer is OPV. Now, which is the freeze sensitive vaccines? The freeze sensitive vaccines are hepatitis B. It is the most freeze sensitive. You have penta, PCV, IPV, DPT, TT. So hepatitis B, pentavalent, pneumococcal vaccination, DPT and TT. All these vaccines are freeze sensitive, and of this the most freeze sensitive is the hepatitis B vaccine, and these vaccines are never frozen. You should not freeze them. You can store them in the refrigerator, but you should not freeze them. Okay. So, which is the most heat sensitive vaccine? The right answer is polio vaccine. Okay. Now, live vaccines are all except. So, what are we have different types of vaccines. We have live vaccines and killed vaccines, and also we have another subgroup known as subunit vaccines. So, which are the live vaccines? So, the live vaccines, the examples of live vaccines are, a few examples that you want to remember is MMR vaccine is a live vaccine. OPV, oral poliovirus, is a live vaccine. Oral typhoid vaccine is a live vaccine. BCG is a live vaccine. Varicella is a live vaccine. Yellow fever vaccine. All these are live vaccines. So, if you remember the name of the live vaccines, then you can easily remember that most of the other vaccines are killed vaccines. So, these are some of the named very important live vaccines to remember. So, of these options, which one is not a live vaccine? BCG is a live vaccine, measles is a live vaccine, polio you have OPV and IPV. OPV is a live vaccine, whereas IPV is a killed vaccine. Since you have just mentioned polio, it's an arbitrary choice, but rabies definitely is a killed vaccine. So here the option is rabies vaccine. Okay. Moving on. Now what is this? This is called as a vaccine vial monitor. For what is vaccine vial monitor used? It is used for temperature damage or heat damage. It is used for detection of temperature or heat damage. That is, if the cold chain is properly maintained, then what should happen? There is an inner square and it is surrounded by an outer circle. The inner square should always be lighter than the outer circle. If the cold chain is not properly maintained or heat damage has taken place, then the inner square become as dark as or even more darker than the outer circle. In which case, you should not use the vaccine and you have to discard the vaccine. So that is known as vaccine vial monitors used for detecting heat damage. Now, they have in this question what they have asked, they asked which of the following tests is used for checking the viability of a vaccine after freezing. So after freezing, the test we use is something known as shake test. The shake test is used for detecting freeze damage. For heat damage, you use vaccine vial monitor. For freeze damage, you use shake test. And what is Hable test used for? Hable test is used for detecting or checking the viability of rabies vaccine. It is used for checking the viability of rabies vaccine. Okay. So that is that. Moving on. So DPT vaccine is given to a child 6 weeks following which the baby develops inconsolable crying. In 10 weeks, what would be the next step? So at 6 weeks, DPT vaccine was given, and at that time the baby had inconsolable crying. So they asked, what should you do at 10 weeks of age? One option is give DPT, give DT, don't give DPT, give DPT, but after 1 month. So we already discussed it. Inconsolable crying after DPT is a known side effect. It is not a contraindication to give DPT vaccine. So the DPT vaccine which is coming in due in the next schedule can be normally given. There is no change in the vaccination schedule. The only contraindications are two, that is anaphylaxis to the previous dose, and the second one is if the baby developed encephalopathy after the vaccination within 7 days of giving the vaccine. These are the only two absolute contraindications for giving DPT. All the rest are not contraindication and you can give DPT vaccine in the next date. Okay. So giving DPT in the 10 weeks is the right option. An unimmunized child, next question. An unimmunized child of age 13 months Comes to your OPD. Now, according to the latest schedule, which vaccines will you advise? So, here you have a 13-month-old child who is not vaccinated. So, you have to give the catch-up immunization. So, in catch-up immunization, what all you have to give? BCG, do you give BCG? BCG is not given after 1 year. So BCG, so this child is 13 months of age. So there is no need for giving the BCG. Then what are the other vaccines you have to give? You have to give OPV. 3 doses of OPV has to be given. Pentavalent. 3 doses has to be given. IPV, 1 dose. And measles vaccine, 1 dose has to be given after 13 months. So the right option is 3 doses of OPV, 1 dose of IPV, 3 doses pentavalent, and 1 dose of measles. That is the right answer. So that is how you do catch-up immunization for a 13-month-old child who come to your OPD without taking any of the vaccines. Now, pentavalent vaccine offers protection against which of the following infections? So what is the content of pentavalent vaccine? So pentavalent vaccine contain diphtheria, pertussis, tetanus, hepatitis B, and Haemophilus influenzae. So the right option is option C. The contents of penta means 5, right? So it contains D, P, T, diphtheria, pertussis, tetanus, then hepatitis B and Haemophilus influenza B, HIP. So these are the 5 components of pentavalent vaccine. Now, what does the line marked with the arrow represent in the graph shown in the immunoglobulin level in infants? So here you have this graph. So they are asked about this one. Which one? This graph. So it is initially very high. So this is the birth of the child. 0 means birth. So 6 months before to 6 months after, while the baby is on breast milk, breastfeeding, and while the baby is intrauterine. So what will be the antibody which is very high in the baby during that? It is basically maternal antibodies while the baby is intrauterine and the initial 6 months of breastfeeding. And which is the maternal antibody that is very high in the baby? The type is IgG. So the answer will be maternal IgG. Okay, so now what are the other curves? So the first one is passively transferred maternal IgG, and then after that what happens, slowly the IgG comes down and IgM takes place, and then the baby by themselves develop IgG antibodies and Ig antibodies, and Ig antibodies are also derived to the baby with the help of breast milk. The most important immunoglobulin which is contained in breast milk is immunoglobulin A. Okay, now moving on to the next question. Okay, so that is about the vaccination. Now we'll move on to the fluid and electrolytes part. Okay, the fluid and electrolytes part, there are some important questions. We'll discuss that. Now, the predominant buffering system in the blood plasma is. So they asked about what are the buffers. So basically, always our body is in a state of acid-base homeostasis. So in order to maintain this homeostasis, whenever the pH it goes, normally the pH of the body is between 7.35 to 7.45, that is the normal pH of our body. And if this pH shows an increase or a decrease, that is, in order to prevent the baby body from going into acidemia and alkalemia, we have certain buffering systems in the body. And which are these buffers in the body? The buffers in the body are, we can have acid buffers, then you have respiratory buffer, and finally you have the renal. The acid buffer is the most fastest acting buffering system. And the most important component of that is bicarbonate. HCO3 or bicarbonate is the most important component, and it also contains certain other proteins also help in this, like albumin, hemoglobin, phosphate, and even bone can act as a buffer. Okay, and this is the most important acid buffer in the body. Most important is bicarbonate. Then you have the respiratory buffer. The respiratory buffer is basically the buffer which acts very fast. but not as fast as the acid buffer, but more faster than the renal buffer. So what you do, it mainly by increasing the respiratory rate, it can regulate carbon dioxide retention and carbon dioxide washout. So by increasing or decreasing the respiratory rate, it can maintain. If the respiratory rate increase, there is carbon dioxide washout causing alkalosis. If the respiratory rate decrease, there is carbon dioxide retention resulting in acidosis. Okay, then you have another buffering system, and that's the most important buffering system in our body is renal. It is the most important buffer in our body, but it is very slow to act. But it acts very slowly. So these are the three different types of buffers. So they have asked the predominant buffering system in the blood plasma is. So they are asked about the acid buffers, and about the acid buffers, which is the most important. Hemoglobin is there, plasma proteins is there, phosphate is there, but the most important one is bicarbonate buffer. Okay. Moving on. All of the following are used in the treatment of hyperkalemia except. So what is hyperkalemia? Hyperkalemia is basically if the serum potassium level is more than 5.5 milliequivalent per liter, you call it as hyperkalemia. And what are the ECG changes that you get in hyperkalemia? The ECG changes in hyperkalemia include tall T wave, ST depression, increase PR interval increases, flat or flattening P wave. Okay, now what happens if the potassium becomes very high as 6.5 to 8? Then it can result in something known as widening of the QRS complexes. Widening of the QRS complex happens when the potassium level is between 6.5 to 8. And if the potassium level becomes more than 8, what happens? It results in sine wave pattern, which is a highly unstable rhythm and can easily decompose or can compensate into ventricular fibrillation or asystole. So that is why we have to aggressively manage hyperkalemia, otherwise it can go into life-threatening arrhythmias. Now, so how do you treat? How do you treat hyperkalemia? The treatment of hyperkalemia includes the first method is we have to immediately stabilize. Membrane is very unstable because of hyperkalemia. So in order to stabilize the membrane, you give certain membrane stabilizer. The most important one is 10% calcium gluconate. You give membrane stabilizer 10% calcium gluconate. Then there are certain basically what happens is that potassium is a predominantly an intracellular ion. So when there is hyperkalemia, you can give certain medication to increase the cellular uptake of potassium. So there are certain substances which can increase the uptake of potassium into the cell so that the plasma level of potassium comes down. So which are these drugs? The drugs which increase the cellular uptake of potassium. Examples are insulin, dextrose, infusion, sodium bicarbonate, beta 2 agonist like salbutamol, which can be given as nebulization. Okay, then you can give medication to increase the potassium excretion. How can you increase the potassium excretion? You give certain potassium binding resins, which will bind to the potassium in the intestine and will increase the excretion of potassium. So that is known as potassium binding resins. Example is K-xylate. And loop diuretics like furosemide can also be used for reducing the serum potassium level. Loop diuretics. But if all these measures fail, like if the patient is having life-threatening hyperkalemia, refractory to all these medical management, then the only option that you have left behind is to do a dialysis, either hemodialysis or peritoneal dialysis. So the final option is hemodialysis by peritoneal dialysis. Okay. So these are the methods of correction of hyperkalemia. So what is the question here? All of the following are used in the treatment of hyperkalemia except. So what is the right answer? Calcium gluconate, yes, it is used. Sodium bicarbonate, yes. Insulin, yes. But hypertonic saline is not used in the management of hyperkalemia. Now, a little bit about hypokalemia. Since we have talked about hyperkalemia, you can always get a question from hypokalemia also. So, about hypokalemia, what is the definition of hypokalemia? Hypokalemia is defined as potassium less than 3.5 milliequivalents per liter. What are the ECG changes that you can get in hypokalemia? You can get U waves. You can give T wave inversion. And there is something known as Torsades de pointes. That is another ECG change that you can get in hypokalemia. Torsades de pointes. And hypokalemia, it increases digitalis toxicity. That is another important MCQ. If you are giving digoxin and if there is coexistent hypokalemia, it increases the digitalis toxicity. So in a child who is on digoxin, you should always ensure that the child is not having hypokalemia because the cardiac toxicity of digoxin get accentuated or increased in the presence of hypokalemia. Okay, so that is about hypokalemia. Moving on to the next question. High osmolality with high anion gap is seen in. So now they are asked about metabolic acidosis. So metabolic acidosis is the topic we are going to deal with it. Now, metabolic acidosis can be of two types. It can be a normal anion gap metabolic acidosis or high anion gap metabolic acidosis. Can be two types. Can either have normal anion gap or we can have high anion gap. What are the causes of normal anion gap metabolic acidosis? It usually happens when you have a loss of bicarbonate. For example, in the case of diarrhea, where the excessive diarrhea and loss of bicarbonate is lost from the body, then you get kind of normal anion gap metabolic acidosis. Or if the child is having RT, renal tubular acidosis and bicarb loss in the urine. Or if the baby has undergone a urinary diversion procedure. That is also one of the reasons for normal anion gap metabolic acidosis. And then you have ammonium chloride ingestion. And post hypocapnia. These are some of the reasons for normal anion gap metabolic acidosis. Now, what are the causes for high anion gap metabolic acidosis? High anion gap metabolic acidosis can occur because of multiple reasons. It can be because of lactic acidosis. Why does lactic acidosis happen? Whenever there is hypoxia, when there is tissue hypoxia or ischemia. Hypoxia or ischemia can be because of shock, decreased blood supply, anything like that. What happens is increased anaerobic metabolism, resulting in excessive production of lactic acid as a byproduct, and that can result in lactic acidosis. Second one, it can be because of ketoacidosis. There is excessive deposition of keto acids. It can occur in diabetic ketoacidosis and starvation ketoacidosis. Okay, these are some of the two important reasons for ketoacidosis. And third one is that it could be because of certain poisoning. Poisoning can also cause excessive or high anion gap metabolic acidosis. Example of certain poisonings are methanol poisoning, ethylene glycol poisoning, salicylate poisoning, toluene poisoning, and paraldehyde. These are some of the important causes for high anion gap metabolic acidosis. Now let's look at this question. So high osmolality, high anion gap is seen in diarrhea, no, it is normal anion gap. Distal RTA, it's normal anion gap. Ammonium chloride intake, all these are normal anion gap. So the only condition where you can get high anion gap is methanol poison. Okay, so that is about that. Moving to the next question. Hypernatremic dehydration in children leads to irritability, restlessness, weakness, lethargy, and fever. What is the most devastating consequence of hypernatremia in children? So they asked about hypernatremia. So what is the definition of hypernatremia? Hypernatremia is defined as serum sodium more than 145. As you all know, sodium is the most important electrolyte which contributes towards the serum osmolality. So when there is increase in the serum sodium level, there is a proportional increase in the serum osmolarity. So what happens, for example, this is the cell. Okay, when this is the plasma. So the plasma contains excessive amount of sodium. So the osmolality is increased. So because there is excessive osmolality, what happens? Water from the cell moves out as compensation. In order to decrease the osmolality outside, the water from the cell moves from in to out. So what happened to the cell? The cell undergoes shrinkage. And this shrinkage happens on the endothelial cells as well. And when this endothelial cells shrink, there can be capillary break. The capillary wall gets break, and that can lead to brain hemorrhage. It can happen anywhere, but the most common site is the CNS, and thus the child can develop a complication like intracranial hemorrhage. So the most devastating consequence of hypernatremia is brain hemorrhage. Now, another question that you can get is, what if there is a rapid correction of hypernatremia? So, if you give rapid correction, so already the cell might be in a state of compensation. But if you rapidly correct this hypernatremia, the child, all the fluid may enter back into the cell altogether, and the cell may suddenly swell up, and that can result in a condition known as cerebral edema. So rapid also, what happens is that hypernatremia will lead to cell shrinkage and brain hemorrhage. But if rapid correction occurs, the cell swells up and can cause brain edema. Okay. And so the rate of correction of hypernatremia as well as hyponatremia should take slowly. So the slow correction should take place to avoid this. And what is the desired correction? It should be 0.5 milliequivalent per hour or 10 to 12 milliequivalent per day. That is the desired correction of hyper or hyponatremia. This can be asked as a question. If the correction happens at a faster rate, you have to bring it down, otherwise complications can happen. Now, a 5-year-old child comes with no dehydration. Plan A was proposed for management. How much ORS should be given per stool? So here they asked about plan A of management, right? So the plan A management. So it's very easy. Plan A management, how it is? The management of plan A is basically, plan A is per stool 10 ml per kg per stool. But here the question, the problem is that they are not given the weight of the child. So if you do not have the weight of the child and if you only have age of the child, then you can use this chart. That is, if the age of the child is less than 2 years, you give 50 to 100 ml. If the age is between 2 to 10 years, you give 100 to 200 ml. And if it is more than 10 years, you give as much as want or ad libitum. That is, you can give it according to the thirst of the child. So less than 2 months, it is 50 to 100. 2 to 10 years, it is 100 to 200. And more than 10 years, it is as according to the requirement of the child. Okay. Now let's quickly revise how do you classify dehydration. Dehydration, you look at the following parameters: sensorium, eyes, tears, how is the mucosa, that's the tongue and the mouth, thirst, skin pinch. If the baby is having very alert sensorium and the eyes are normal, tears are present, oral cavity is moist with a normal thirst and skin pinch returns very fast, then you call it as no dehydration. If there is no dehydration, then the management is simply plan A. That is, you give ORS 10 ml per kg after each episode of loose stool. What if the patient is having some dehydration, as evidenced by the child is having restlessness, the child is having sunken eyes, tears are absent, oral mucosa is dry, the child is excessively thirsty, the skin turgor, it goes back very slowly. In which case, you can call that the patient is having some dehydration. And if it is some dehydration, what is the management you give? You give plan B management, in which apart from plan A, you have to give deficit correction. That is, deficit replacement is calculated as 75 ml per kg is given over 4 hours. You can give either ORS, or if you're giving intravenously, you give ringer lactate. The fluid of choice for correction of dehydration is always ringer lactate. Now, severe dehydration, if the baby is very lethargic, the baby's eyes are very much sunken, tears are absent, oral mucosa very dry, the baby does not drink or drinks very poorly, and skin turgor goes back very slowly. In which case, the type of management that we use is plan C. In plan C, how do you give? You give 100 ml per kg IV ringer lactate, and you divide it into, first you give 30 ml per kg and after that you give 70 ml per kg. If the age of the child is less than 1 year, you give 30 ml per kg over 1 hour and 75 ml per 70 ml per kg over 5 hours. The age of the child is more than 1 year, then you give 30 ml per kg over half an hour and 70 ml per kg over 2.5 hours. So the just basics. You have to know all these things, so just revise it. So this is how you manage dehydration. Now, through peripheral line, maximum percentage of dextrose that can be given is. So if you're correcting hypoglycemia and you're giving a higher concentration of dextrose, through peripheral line, the maximum concentration of dextrose that you can give is 12.5. If you want to increase the glucose concentration of the infusing fluid to above 12.5 percentage, you have to put in a central venous access. The right answer here is 12.5. Okay. Next question. What is the most sensitive indicator of depletion of intravascular volume? So whenever the intravascular volume falls, that is whenever there is hypotension or there is a decreased circulating volume of blood, the first thing that will happen, which you can detect early, or the first clinical sign that can pick up, is increase in heart rate. So increased heart rate is the most important sign of reduced intravascular volume. And that stage, if the BP is normal, you call it as compensated shock. If there is tachycardia and there is hypotension, then you call it hypotensive shock. So which is the first clinical sign? It is always heart rate. And what will happen to the heart rate? The heart rate increases. That is how, what is the mechanism? Basically, the cardiac output is equal to stroke volume into heart rate. So whenever the stroke volume decreases, in order to maintain the cardiac output, the heart rate compensatingly increases. So that is a mechanism by which the heart rate increases whenever there is a stroke volume decrease, because we want to maintain the cardiac output. When this compensatory mechanisms fail, what happens is that the cardiac output decreases, and because of the reduced cardiac output, the BP also comes down and the patient goes in for hypotension. So that is the important point about shock, compensated and hypotensive shock. Moving to the, so that's about important points about fluid and electrolytes. Now moving to some of the important points about infections. So here, according to IMNCI, in a baby of 6-month-old age, the criteria for fast breathing is more than. So what is the criteria for fast breathing in IMNCI according to the age of the child? So according to the age of the child, if the age of the child is less than 2 months, if the respiratory rate is more than 60 per minute, then it is fast breathing. If the age of the child is between 2 months to 1 year, then more than 50 per minute is taken as fast breathing. If the age of the child is more than 1 year, then tachypnea if the child is having respiratory rate of more than 40 per minute. Okay, so that is the definition of fast breathing. Okay. Now, next one is about how will you manage a pneumonia or fast breathing in a child according to IMNCI or ARI control program. According to the ARI control program and the IMNCI, the management is different if this depending on the age of the child. If the age of the child is less than 2 months and if the baby is having fast breathing or chest indrawing, then it means that the child is having severe pneumonia. Okay, if there is fast breathing and chest indrawing without warning signs, you classify it as severe pneumonia and you either refer, or if you are in a tertiary care center, you admit the child and start the child on antibiotics. And the antibiotic of choice is ampicillin plus gentamicin. That is the antibiotic of choice. Now, what if age of the child is between 2 months to 5 years? If the age of the child is between 2 months to 5 years, then if the child is having fast breathing plus or minus chest indrawing, then you classify it as pneumonia. Then it is not severe pneumonia, you just call it as, so here it is severe. If the age is between 2 months to 5 years, if fast breathing or chest indrawing is present, you just classify it as pneumonia and you start the trial on oral treatment. And what is the oral drug you use? You use amoxicillin. It is used at a higher dose at 80 mg per kg per day. Okay, if along with that danger signs are present, if danger signs are present, then you should call it as severe pneumonia and admit and start on IV antibiotics. Okay, danger signs are present, then you call it to severe pneumonia and then you admit and start on IV antibiotics. So what are the danger signs? The danger signs are cyanosis or bluish discoloration, seizures, could be hypoxic seizures, poor feeding or lethargy, if the child is having a stridor at rest, if the child is having severe acute malnutrition. All these are considered as danger signs, and if any of these danger signs are present, then the child is considered to be having severe pneumonia and it requires admission and treatment with IV antibiotics. So that is about the IMNCI and ARI control program. Moving on to the next one. A child has a fever and rash spreading from face behind the ears to the body parts. On examination, coptic spots is present. The likely diagnosis is, so it's a straightforward question. You have all the clues in arriving at the diagnosis. So you have a rash with fever appearing from behind the ears and face and along with coptic spots. So the diagnosis without a doubt measles. So some important points about measles. It is an RNA virus. The period of infectivity is 4 days before the onset of rash to 4 days after. So 4 days before to 4 days after is the infective period. And it is characterized by the 3C, that is cough, coryza and conjunctival congestion. Cough, coryza conjunctival congestion. This is followed by the appearance of something known as Koplik spots, which is whitish color discoloration to erythematous base, which can be seen on the buccal mucosa. Where in the buccal mucosa? Opposite second lower molars. You can see that. And this is followed by the characteristic rash. What is the characteristic of the rash? The rash typically appears behind the ears and the face and then spread towards the whole body. Okay, and the rash, it appears from head, then it goes downwards and it disappears in the same order. And when the rash disappears, it leaves behind a particular pigmentation known as briny desquamation. Briny desquamation. If you look at the microscopy of these rashes, you can see certain giant cells. And what is the name of these giant cells? These giant cells is known as Wharton Finkeldy giant cells. MCK. These are the characteristic giant cells seen in the rash of measles. Now, what are the complications of measles? Complications of measles, the most common complication is otitis media and pneumonia. And the most common late sequelae is, or the most dangerous late sequelae is SSPE, subacute sclerosing panencephalitis. That is a very fatal condition and it is very rare, but if it occurs, it is associated with high rates of fatality. Now, what is the treatment of measles? It's basically supportive treatment and you always have to give vitamin E. Vitamin A is given in the treatment of measles and how many doses is given? 2 doses. On day 0 and day 1. 2 doses of vitamin A. Vitamin A is also given as a part of treatment of measles. Now, let's have a quick look at what are the others. So, in the case of measles, the 4th day the rash appears. So, what are the other fever with rashes that you have to know about? The other fever with rashes, you can remember it by the mnemonic very sick person or children must take double tablet. Very sick patient must take double tablet. So on day 1, if you get the rash, it is varicella. On day 2, if you get the rash, it is scarlet fever. On day 3, it is rubella. Day 4, measles. Day 5, typhus. On day 6, dengue. And day 7, typhoid. So that is the day or depending on the day of appearance of typhoid. 1, 2, 3, 4, 5, 6, 7. So day 1 it is varicella, day 2 it is scarlet fever, rubella it is on day 3, measles it is on day 4, and then typhus day 5, dengue day 6 and typhoid it is on the day 7. Okay, so that is about fever with rashes. Now, a 14-day-old child infant presents with conjunctivitis, following which 5 days later the patient developed pneumonitis. What is the most likely causative agent? So it's an infant or a newborn. 14-day means it's a newborn. So the most common cause of neonatal conjunctivitis, which can progress to pneumonitis, is chlamydia. Chlamydia trachomatis. So the right option here is chlamydia trachomatis can cause neonatal conjunctivitis. The other organisms which can cause neonatal conjunctivitis is gonococcal species. But since the child is also present pneumonitis, the right option here will be chlamydia trachomatis. Okay. Moving on to the next part. That is respiratory. So we have covered some of the important questions in infections. Moving on to respiratory system. So, an 8-year-old child presents prolonged cough for 7 months. hemoptysis of 1 month, and fever for 7 days. The chest x-ray is shown below. What is the diagnosis? So you have cough, hemoptysis and fever. So on the x-ray, what can you see? You can see that there is a homogeneous areas of infiltration, more on the right when compared to the left. So what is it? It is consolidation. It is not hydatid cyst. It is not lung abscess. In the case of hydatid cyst, you can see a well-defined cystic collection. Lung abscess, you can see a thick-walled cyst-like area with sometimes air fluid levels. If it's a congenital thoracic malformations, the classical picture will be present. So here the right option is consolidation. So some important points about pneumonia in children. So pneumonia in children, the most common cause of death in children of less than 5 years is pneumonia. So pneumonia is the most common cause for under 5 mortality. Now, depending on the age of the child, if it is less than 3 weeks of age, then the most common cause is bacterial. Examples are group B streptococci, E. coli, etc. If the baby is between 3 weeks to 4 years of age, here the most common cause is viral, and the most common virus being RSV. And after that only comes bacteria, and among bacteria the most common is group B streptococci. That is Streptococcus pneumococci. Okay, so 3 weeks to 4 years, it is more viral, and of the virus, the most common is RSV, and after viral infections come bacterial infection, and the most common bacteria in this age group is pneumococcus. And after 4 years, the most common organisms are atypical organisms like mycoplasma. Okay, followed by pneumococci, followed by chlamydia. So they can ask you a question. After 4 years of age, the most common is caused by atypical mycobacteria, like atypical microorganisms like mycoplasma, Klebsiella, etc., chlamydia, etc. And between less than 3 weeks, it is more bacterial, group B streptococcus and E. coli. And between 3 weeks to 4 years, the most common is viral. Of the virus, most common is RSV, and followed by bacteria. Among bacteria, the most common is pneumococcus. So the pneumonia that is being caused by mycoplasma species and chlamydia species is also known as walking pneumonia. Why it is known as walking pneumonia? The child might be having pneumonia, but the X-ray findings will be very much, a lot of haziness might be there, but the child might not be that much symptomatic or dyspneic. And hence we call it as walking pneumonia. Okay. Now, moving on to so that is the importance of pneumonia in children. Moving on to the next question. It's a question coming from CNS. Choose the correct statements about juvenile myoclonic epilepsy. So what is myoclonic seizures? Myoclonic seizures are brief, symmetric muscular it's an electrical shock-like activity. All the muscles symmetrically contract. So it's a brief, symmetrical, very fast or rapid contraction of muscles. Brief, symmetric, muscular contraction. And there are different types of myoclonus. It can be, one is benign sleep myoclonus. It is seen in certain newborn babies, that is during sleep they have brief myoclonus, but during when they are awake there is no problem. It is not associated with any neurological impairment. The EEG is normal, and usually by the age of 2 years it disappears. So that is known as benign sleep myoclonus. EEG normal, usually stops by 2 years of age. Then you have the typical myoclonic epilepsy. And then you have something known as juvenile myoclonic epilepsy or JME. So, juvenile, as the name suggests, happens in the juvenile age group. What is this juvenile age group? In children between 12 to 16 years. And it is usually associated with a mutation in GABA receptor mutation. And what are the characteristic clinical features? There is myoclonus. On waking up from the bed, the baby has, the child will have myoclonus. There will be early morning GTCS. Usually in the early morning hours, they will have seizures. And the drug of choice is valparin. Okay. Now there is another disease known as Lephora body disease. What is this Lephora disease? It's a progressive myoclonic epilepsy. Progressive myoclonic epilepsy is known as Lephora disease. So what is the question here? Choose a correct statement about juvenile myoclonic epilepsy. Polygenetic inheritance. Lamotrigine decreases the myoclonus. Benzodiazepines alone can treat myoclonus. So valproate should be avoided. So valproate is the treatment of choice. So this is not the right answer. Polygenetic inheritance, yes. Lamotrigine decreases the myoclonus. Yes. Benzodiazepines alone can treat myoclonus. No. So the option is option A, B and C. So that is the right option. Now, a baby 18 months of age presents with low-grade fever for 3 days. On examination, he has a bulging anterior fontanelle. CSF examination revealed low glucose. What is the most likely diagnosis? So what is the diagnosis here? So this is a baby 18 months with low-grade fever, and the low-grade fever is present for 3 days. On examination, there is a bulging anterior fontanelle. Okay. CSF examination revealed low glucose. So what is the most likely diagnosis? So what is your diagnosis? The diagnosis is meningitis. Why do you say it is meningitis? Because there is high grade fever, bulging anterior fontanelle, and the CSF examination has showed low glucose. So how do you look at, or what are the important points that you need to remember about meningitis? Etiology. What are the common organisms? So we have already dealt about the important etiologies in pneumonia. Now before dealing with meningitis, we'll take a short break. Mm. Welcome back. So, in the comment box, someone has asked, can valproate be given in a child less than 7 years of age? So, yes, valproate has got a problem. What is the problem with valproate? Because it's an enzyme inducer, right? So, if the child is having any inborn errors of metabolism, in such cases, if you give valproate, it can even worsen the condition. So, 7 years is not the age. In any child who's less than 3 years of age, if the child has present to you with seizures without any cause or developmental delay, valproate should be used with caution. Because if you're dealing with a child who could be probably having some metabolic problem, and if you give valproate for that seizures, it may sometimes worsen the underlying metabolic disease. So it's not 7 years of age in children who's less than 3 years of age with seizures and developmental delay for which you do not have a certain diagnosis, or if you're suspecting a metabolic disease in your diagnostic differential diagnosis, then you should use valproate with caution. Otherwise, less than 7 years, valproate is not generally, it's not a contraindication to give valproate in children less than 7 years of age. Okay, so I hope I've cleared your doubt. Now, moving to what we are dealing with. So, we were talking about meningitis, right? So, what are the important etiological agents for meningitis in children? So, the etiological agent for meningitis is if the child is less than 2 months. The most common organisms which can cause meningitis is gram-negative organisms. Then group B streptococcus and listeria. Listeria is an organism which can cause meningitis in those babies who are having certain T lymphocyte defects. In people who are having T lymphocyte defects. In such children, they can have increased susceptibility due to develop meningitis due to listeria. If the baby is between 2 months to 2 years of age, then the most common organism is Haemophilus influenza. Between 2 to 12 years of age, the commonest organisms is Streptococcus pneumoniae, that is pneumococci, and Neisseria meningitis. Neisseria meningitis, the especially increased risk in children with complement factor defect, especially terminant complements like C5 to C8. If they are having any inherent disorders of the complement system, they are at higher risk of developing meningitis due to Neisseria. So, okay, so these are the etiological agents. So, what are the clinical features? The child will present fever, irritability, meningeal signs. What are the meningeal signs? There can be neck stiffness. Kernick signs might be positive, and Brudzinski sign might be positive. You can get a bulging anterior fontanelle. Child may present you with seizures. There can be papilledema, altered sensorium. There can be cranial nerve palsies, etc. These are all other wide range of symptoms which a child with meningitis can present to you. So, how do you diagnose? The diagnosis of meningitis is done by doing CSF study. And how do you do the CSF analysis? By doing what is known as lumbar puncture. Okay, so you look at the CSF, and by looking at the CSF, you can differentiate whether it is a bacterial meningitis, viral meningitis, or a tuberculous meningitis. So how do you differentiate? Bacterial, viral, or tuberculous. So what will be the opening pressure? The opening pressure will be very high in bacterial meningitis. It can be high in viral meningitis, or it can be normal. It is usually high in tuberculous meningitis. What would the total count? The total count is generally between 100 to 5000 in bacterial meningitis, and more commonly it contains neutrophils or polymorphonuclear lymphocytes. In viral meningitis, it contains around 100 to 1000 cells, and it will be predominantly lymphocytes. Tuberculous meningitis, it will contain around 10 to 500 cells, and they'll also be predominantly lymphocytes. Okay, what will be the protein content? The protein content will be high in bacterial meningitis. In viral meningitis, it can be mildly increased. In tuberculous meningitis, it will be very high. Okay, now what will be the glucose content? The glucose content will be reduced in bacterial meningitis. It will be normal in viral meningitis, and tuberculous meningitis, it will be very low. Maybe it will be less than 40. So this is how, with the help of the CSF analysis, you can differentiate between bacterial, viral and tuberculous meningitis. And if the diagnosis of meningitis has been made, how do you treat? The treatment is, empirical treatment is done with ceftriaxone plus vancomycin. Okay, what if it's a tuberculous meningitis? If it is a tuberculous meningitis, you have to give ATT with steroid. And so that is one indication for giving steroids in tuberculosis is if there is tuberculous meningitis. And the duration of ATT is 12 months. Generally, if there is tuberculosis, you give the treatment for 6 months. But if it is meningitis, there are two important differences. One is the treatment is given for a period of 1 year, and you always give steroids along with it. So this is some of the salient features about meningitis. Now, moving on to oncology, a question about oncology. A 9-year-old boy presents with a lytic lesion in the mid shaft of tibia. On histopathological examination, there is grooved nuclei, giant cells, eosinophilic cytoplasm, and fibroblastic proliferation. So, all these findings are pointing towards the diagnosis of Langerhans cell histiocytosis. That is grooved nuclei, giant cells, eosinophilic cytoplasm, and fibroblastic proliferation. These are the typical microscopic features of Langerhans cell histiocytosis. So, about LCH. LCH is a disease which commonly is seen between children between 0 to 15 years of age group, and it has got a wide spectrum of involvement. It can either be a multi-system disease or a single system disease. Okay, wide spectrum. And the most common site of involvement is bone. 80% of them is involved in the bone. And then followed by skin. Then you have lymph nodes. And then you have the liver and the spleen. And the most common gene mutation is BRAF gene mutation. Okay. Now, what are the types of LCH? LCH can be divided into two types. It can be uni-system or it can be multi-system. Can be uni-system or it can be multi-system. Among the uni-system, again, it can be divided into unifocal or multifocal. The unifocal disease is what is known as eosinophilic granuloma, wherein you will get the type of presentation as how you got in this question, that is a well-defined lytic lesion on the bone. Okay, now multifocal is what is known as Hand-Schuller disease. Hand-Schuller disease is characterized by the triad of diabetes insipidus, exophthalmos, and calvarium bar scalp defects. And the multi-system disease or the severe form of LCH is known as lateral sieve disease. This is the disease which is characterized by all these other features will be present along with other features like fever, weight loss, lymphadenopathy, hepatosplenomegaly, all these will be present. Okay, so here there is a table. Letrozole disease is the multi-system disease. Eosinophilic granuloma is the unifocal unisystem disease. Hand-Schüller-Christian disease is the unisystem multifocal disease. Okay, so these are the important features of variation. And what are the most important feature or the electron microscopic feature that you see? You see Berber granules, which is characterized by the tennis racket appearance. That is an important MCQ question. And which is the molecular marker SD1, SD100, S100, CD1A. These are the important immunohistochemical markers of Langerhans cell histiocytosis. That is also important MCQ point. S100 or CD1A. And on light microscopy, what can you see? You can see Langerhans cells, large multinuclear cells. Okay, so that is about that. Now, last option is how do you treat? So that is this question about 1-year-old child presents cervical lymphadenopathy. On evaluation, there is thrombocytopenia and the X-ray of the skull has shown below. And what is this you see? What are you seeing here? You are seeing the lytic lesions of LCH. These are the lytic lesions. So here the child is having lymphadenopathy and thrombocytopenia and skull X-ray lytic lesion. So what is the type of disease? This is a multi-system disease. The bone marrow is involved, the lymph node is involved, the bone is involved. So this is a multi-system disease. So if it's a multi-system disease, the treatment involves chemotherapy. And which is the agent used? Vinblastine along with steroids. That is the agent which is used for the treatment of multi-system LCH. If it's a single system LCH, it has high chance of spontaneous remission. So what do? You just need to give curate or steroid injection or low dose local radiation therapy. So if it's a unisystem disease, a mild disease can undergo spontaneous remission, or you can also give a local radiation therapy or a surgical curettage. But if it's a multi-system disease, you'll have to treat more aggressively with chemotherapeutic agents like vinblastine, and steroids may also be required. So that is the answer. So what is the answer? The answer here is vinblastine. The chemotherapeutic agent used for the treatment of LCH is vinblastine. Okay. Now, a 2-year-old child presents to you with the following abnormality. There is history of similar illness in the father. What might be the underlying condition responsible? So here what you're seeing? What you're seeing is a white. Here when you're looking for the red reflex, on one eye there is a white color. And that is known as leukocoria. And leukocoria, along with a positive family history, means it is because of the mutation of the RB gene or retinoblastoma gene mutation. And what are you looking at? You are looking at a malignancy known as retinoblastoma. Okay, so that is the right answer. The option here is retinoblastoma. Now, a good prognosis factor for ALL are all except. Okay, so what they are asking to you now? Now you are asking about ALL, acute lymphoblastic leukemia. So basically, the most common childhood cancer is leukemias. More than solid organ tumors, the most common cancer, the childhood cancer which is the most common, it is leukemia. Of the leukemias, the most common one is ALL. ALL is more common than AML. So it is the most common childhood cancer. And how can the child present the clinical features? The child may present to you with increasing pallor. They may present bleeding manifestations, recurrent infections. On examination, you can get bone tenderness. There may be lymphadenopathy, hepatosplenomegaly, etc. Okay. And there are certain factors in the history or on examination, that will decide whether the child is likely to have a good prognosis or a poor prognosis. And if the child is having more poor prognosis factors, they may require a higher dose of chemotherapy and even cranial radiation therapy. Whereas if it is a low risk factor case, then they can be treated with just standard therapy. So this is important. So we have to know what are the poor prognostic indicators in a child with ALL. So which are the factors indicative of poor prognosis? Factors associated with poor prognosis is, first one is initial total count. If the initial total count is more than 50,000, it is a poor prognostic factor. Age at diagnosis. Age at diagnosis less than 2 years or more than 10 years. Both are poor prognosis. Female sex is a poor prognostic factor. Then certain cytogenetics. Which are the cytogenetics? Translocation 922, 411, 119 and hypoploidy. Hyperploidy is good prognosis, hypoploidy is bad prognosis. Then FAB classification type 3, that is L3, and immunologically or immunohistologically, if TALL has got a poorer prognosis than B-cell ALL. Okay, so these are the poor prognostic factors of ALL. So the question here is, good prognosis factors for ALL are all except hyperploidy is a good prognosis, WBC count less than 5,000, age 10 years, T1221 translocation. So here age 10 years is not a good prognostic factor. Age 10 years is a bad prognostic factor. Less than 2 years and more than 10 years. 10 years or more is poor prognosis. The answer is age of 10 years. Now, what is the most common, another few points about leukemia that you want to know is that what's the most common relapse site? The most common relapse site is bone marrow, and which are known as the sanctuary sites or the extramedullary relapse sites. They are also known as sanctuary sites. Extramedullary relapse sites. They are CNS and the testis. CNS and testis. Testicular and CNS both are sanctuary sites. There is a high risk of extramedullary relapse. Okay, so that is about oncology. Now moving to a few questions on development. When does handedness of a child develop? So handedness means that is we all are differently handed. Like I may be right-handed, another person may be left-handed. So that particular handedness usually develops by 3 years of age. So if handedness develops earlier, that is before 3 years of age, it is always considered abnormal, because early development of handedness could be indicative of a weakness of the opposite side. A child is always preferentially using the one limb in an age before 3 years of age. It may indicate that the child could be having a weakness of the opposite side, like in the case of a congenital hemiplegia, etc. So normal development of handedness, it occurs by the age of 3 years. So handedness is established by 3 years. Early handedness, it's always may be suggestive of weakness of opposite side, like in the case of hemiplegia. What hemiplegia? Congenital hemiplegia. Okay, that is the importance of handedness. Which of the following is considered developmental delay in a 3-year-old? Okay, so in a 3-year-old, what does a 3-year-old do? Unable to copy a square. So when does copying a square comes? Hmm? it usually comes by around 4.5 years of age. So that cannot be taken as a developmental delay. Unable to use a spoon, usually using a spoon comes by 1.5 years of age. Unable to hop on one foot, that comes at 4 years of age. Unable to catch a ball properly, that comes at 4 years of age. So, of this, which developmental milestone is below 3 years? It is using a spoon. So, a milestone which should have been developed at 1.5 years of age, if not developed by 3 years of age, then it is considered developmental delay. All the other milestones given in the options are which are acquired by 4 years only. So, the baby doesn't do that by 3 years, that cannot be taken as developmental delay. So, right option is unable to use the spoon by 1.5 years of age. Okay. Now, developmental milestones, it's very important. Go and read about the developmental milestones, the gross motor, the fine motor, social, personal and social language, vision and hearing. We have already discussed about this in detail in your previous session. It's very important since we do not have time to discuss all together again. We are not discussing here now. But the development, it's very important. Multiple questions have been asked from this area. So we have to learn about the developmental milestones at each and every age. Okay. Now moving on to storage disorders. A child with neurological problems. A bone marrow biopsy is given below. So what is the most likely diagnosis? So here you have a child with certain CNS problems and the bone marrow is done, and what do you see here? What is this particular cell showing? This is what is known as crumbled tissue paper appearance. And in which conditions do you get that? You get that in Gaucher's disease. Okay, now a little bit about Gaucher's disease. What is the enzyme deficiency which occurs in Gaucher's disease? It occurs because of the enzyme glucose cerebrosidase. Enzyme deficiency. And which are the organs affected? The liver, spleen, bone marrow, and CNS. And the characteristic feature, pathological feature is crumbled tissue paper appearance on bone marrow. Now, what about Tay-Sachs disease? Tay-Sachs disease is also known as GM2 gangliosidosis. And it is because of the deficiency of the enzyme hexosaminidase A. And the clinical feature is hyperacusis. That is the most important clinical feature. So because they are having hyperacusis, even because of a small sound, there will be hyper alert. So there will be exaggerated startle response. And they will be having seizures. And this is a very fatal condition. Usually death occurs by 2 to 3 years. That is about Tay-Sachs disease. Another disease that you have to study is Niemann-Pick disease. Niemann-Pick disease is because of the deficiency of the enzyme sphingomyelin, characterized by hepatosplenomegaly and failure to thrive. Okay. Then you have something known as GM1 gang. So Tay-Sachs disease is GM2 gangliosidosis. Then you also have GM1 gangliosidosis, characterized, or it is due to the deficiency of beta galactosidase deficiency. It is characterized by developmental delay, seizures, and increased or exaggerated Mongolian spots, coarse facies. So the some of the important features of GM1 gangliosidosis. And there are all these, many of these conditions is associated with an ophthalmological finding known as cherry red spot. Which are the conditions which is characterized by cherry red spot? You can remember the mnemonic GTNS, where G stands for GM1 gangliosidosis, T stands for Tay-Sachs, N stands for Niemann-Pick, and S stands for San-Philip. Sorry, San-Philip. S stands for Sandhoff's disease. S stands for Sandhoff's disease. Okay, so that is the disease which is characterized by cherry red spot. This can be asked as an MCQ. Okay, now another important disease spectrum that you have to know about is mucopolysaccharidosis. Mucopolysaccharidosis, MPS. Mucopolysaccharidosis are basically different types. Type 1 is known as Hurler. Type 1 is Hurler. Type 2 is Hunter. Type 3 is Sanfilippo. Type 4 is Morque. Type 6 is Meroteox lami. Type 7 is Sly. So these are different types of mucopolysaccharidosis. All these diseases are autosomally recessively inherited except Hunter's, which is X-linked recessive. All others are autosomally recessively inherited. And what is the characteristic X-ray finding you see in this? It is known as dysostosis multiplex. That is a characteristic X-ray finding that you see in children with mucopolysaccharidosis. Moving on to the next question. In which of the following diseases you see the following eye findings? So what do you see in this eye? You can see that there is bony spicules. Bony spicule shaped pigment deposition. And this is characteristic of mitochondrial diseases like Kearns-Sayre disease, retinitis pigmentosa. All these are certain mitochondrial diseases. So in mitochondrial diseases, these findings are seen. Okay, now about dentition. Okay, so here they have asked to match about the time of eruption of the tooth and the particular dentine. So this is actually quite hard question, but we can learn it by in a simpler way. So about dentition, there are certain important points that you have to know. That is, in dentition, there are basically two different types of teeth. What are the two different types of teeth? You have a primary teeth or deciduous teeth, and then you have the permanent teeth. The primary teeth is 20 in number. The permanent teeth is 30 in number. So the first teeth to erupt is lower central incisor. It usually erupts by 6 to 7 months. Okay, lower central incisor by 6 to 7 months. And the last to erupt is the second molar. The first one is lower central incisor by 6 to 7 months. The last one is the second molar. Among the permanent, the first tooth to erupt is first molar by 6 to 7 years. So here you have the first molar, C, 6 to 7 years. So you can rule out by, now we only have two options left, C1, C1. So we have B and C left behind. And then the last is M3. The third molar, it develops by 17 to 25 years. So the third molar is by 70 to 25 years. So now we have ruled out and brought the right option. So if you know two options, then you can remember. So the first molar comes by 6 to 7 years and the third molar comes by 70 to 25 years. So the right option here will be A3, B2, C1 and D4. Okay, so it's very difficult to memorize all the different ages of teeth eruption, but like this, you can guess the answer. And also another code that you can use is number of deciduous teeth in infancy. Is generally age in month minus 6. For example, if it's an 8-month child, the number of deciduous teeth the child is expected to have is 2. If the child is 12-month old, then the number of decibels the child is expected to have is 12 minus 6. That is 6. So that is the number of decibels child in infancy is given by age in month minus 6. Okay, so that is some of the important points about dentition. Now next point is orthopedics. You visit a newborn near your house and notice that the baby is having CTEV. When should you advise the baby's parents for consultation to put a cast? Okay. So here what does the abnormality that you see? The abnormality that you see is CTEV, also known as club foot. And what is the treatment option? The treatment option is initial days what you do is that you give certain manuals or certain massaging techniques you are taught to the baby's parents, so that since this is basically a disorder with the bone and the joint location, if you correct this in the newborn period itself when the joints are relatively flexible, with the help of a cast and these manuals, you can make the shape or the alignment of the bones in the right manner without the need for a surgery. And this method is known as Ponseti method. Ponseti method. And when this should be started, it should be started as soon as after birth, as soon as possible after birth. And the cast is usually applied in a few days. Why this cast is initially applied in the few days itself? Because at that point of time the joints and the ligaments are relatively lax, so it is easily to maneuver them to the required alignment. So if this is not done or if the treatment is delayed, what happens is that the flexibility is lost and the limb may be fixed in that position for a permanent period of time, and the only way out may be surgery. So when is the right time for consultation to put a cast? It should be done within a few days, because if you delay the treatment, the deformity will be more. Okay. Now, a few questions about pediatric surgery. We are moving towards the last part of our discussion. Okay. A 3-day-old neonate presented with recurrent bilious vomiting. X-ray abdomen was done and is shown below. Okay. The X-ray abdomen is done and it is shown below. Which of the following will be the next step in the management of the given patient? So 3 days. So what is the age of the child? It's just 3-day-old neonate. And what do you see in this X-ray? What you're seeing is multiple dilated bowel loops with air fluid level. So from this X-ray, you can make an impression that there is some kind of obstruction. Obstruction is present for sure. That is why there is air fluid levels and dilated bowels. So where is the obstruction? So in the question itself, they are given that they have present with recurrent bilious vomiting. So if there is bilious vomiting, what does it mean? It means that the obstruction is beyond the level of the duodenum. So the most common cause of such intestinal obstruction is, it can be jejunal bar-ileal atresia, or it could be Hirschsprung's disease, or it could be meconium ileus. All these are the different DDs. So in order to find out where is the correct location of this particular obstructions, the next investigation of choice is gastrographin follow through. So a gastrographin is a dye that is being given and you serially take X-ray so that you can see where exactly the narrowing or the obstruction is taking place. So the next treatment option or the next management plan is to take a gastrograph and follow through and see where the exact location of the obstruction is. So that is the right answer. Now, a child is taken to the emergency department with a history of a button battery. On X-ray, it was found in the stomach or duodenum. What is the next step? So, button battery, the problem with button battery is that it can stay in that place, and if it is stays there for too long, what happens is that the fluid from the battery will leak out and can even cause perforation. So, if it is occurs in areas where the mucosa is in very close proximity, like narrow segments of the intestine, it can easily cause perforation. So, if they are present in the narrow parts like the esophagus or in the duodenal bulb, etc., you may have to remove it early. But if it's the wider parts of the intestine, then you can wait for some time. So, since it is present in the stomach, you can wait and watch. But if it stays there for too long, then you may require even endoscopy and removal of the battery. Now, next is a 4-year-old. And for how long you can observe? You can observe for 24 hours. And after that, you have to consider endoscopy and removal. Now, a 4-year-old female came to the OPD with complaints of urinary incontinence and there is continuous dribbling of urine. The image below shows pathology from which the patient is suffering from. So, here continuous dribbling of urine. So, what do you find here? What you are finding here is a bladder exostrophy. The bladder, the anterior wall of the bladder is absent. And because of that, the urine is continuously dribbling. This is an anatomical defects of the anterior abdominal wall. So, the right option is bladder exostrophy. Now, next question is, a 4-week baby presents with noisy breathing which worsens on crying and feeding and improves when the baby is made to lie in the prone position. So, there is stridor. Okay. And this worsens on crying and feeding and improves when the baby is made to lie in the prone position. Laryngoscopy shows the following picture. What is the diagnosis? What can you see here in the laryngoscopy? Here you can see the omega-shaped epiglottis. This omega-shaped epiglottis. And the diagnosis is laryngomalacia. It's a self-limited condition, usually resolves by its own. There is no need for any treatment needed unless there is severe stridor impeding with feeding and there is poor weight gain. There is no need for any treatment, usually resolves on its own. So the right option is laryngomalacia, and what you're seeing here is the omega-shaped epiglottis. Now, here, a 6-year-old child has neurofibromas, cafe spots, and following findings on oral examination. And which gene mutation does this child probably have? So what do you have? The child has neurofibromas and cafe spots. So all these lesions are considering compatible with the diagnosis of neurofibromatosis. And diagnosis NF2 neurofibromatosis gene. So a little bit about neurofibromatosis syndrome. The first syndrome what you have to learn about is neurofibromatosis or von Recklinghausen disease. What are the clinical features of this? It is characterized by cafe au lait spots. There should be more than or equal to 6 in number, and the size should be more than 5 millimeter in pre-pubertal children and more than 15 millimeters in post-pubertal. Okay. Then it is characterized by neurofibromas. How many neurofibromas? There will be more than 2 in number. Then you can see freckling. Where you can see this freckling? It can be seen in the axilla and in the inguinal areas. Then there will be something known as leash nodules. It is seen on the iris. How many will be present? More than or equal to 2. So of this, if 2 or more is present, then you can make the diagnosis of neurofibromatosis. Okay, so that are the important points about neurofibromatosis. What are the other neurocutaneous syndromes of important? Tuberous sclerosis. What are the important points among tuberous sclerosis? Tuberous sclerosis characterized by mutation in TSC1 gene which codes for hamartin, or tuberous TSC2 gene which codes for tuberin. And what are the cutaneous manifestations characterized by adenoma, sebaceum, shagreen patch, ash leaf macule, and subungual fibroma. And it can also be associated with seizures, in which case the treatment that you give is vigabatrin. Okay, then we have another neurocutaneous syndrome of importance, that is Sturge-Weber syndrome. Sturge-Weber syndrome, what are the characteristic features? It is characterized by port wine stain, usually seen on unilateral, single side of the face, usually around the distribution of the ophthalmic division of the fifth nerve. Hemiplegia, intracranial calcification characterized by the appearance called railroad or tram track appearance, and there will also be history of seizures and mental retardation. So these are the other important neurocutaneous syndrome: neurofibromatosis, tuberous sclerosis, and Sturge-Weber syndrome. Okay. Now moving to the last part, that is genetics. Rapid method of chromosome identification is, so we have various method of chromosome identification, of which most rapid method is FISH. So what are the different types of chromosomal abnormalities? The most common chromosome abnormality is aneuploidy. The most common one that you see is aneuploidy. Of the aneuploidies, the most common one is trisomies. And of the trisomies, the most common trisomy is trisomy 16. But usually the trisomy 16 undergoes abortion intrautero itself. So the most common trisomy which manifests or which is born is trisomy 21. The most common live trisomy is trisomy 21. And the most common trisomy of or aneuploidy of sex chromosome. The most common aneuploidy of sex chromosome is Klinefelter's. Okay. Now, what is the most common underlying mechanism of these aneuploidies? It is non-disjunction. The most common mechanism is non-disjunction. Okay. So, in order to detect all these chromosomal anomalies, we have various tests are available. So, what are some of the important tests that you should know? The most commonly used or the most popular one that you all might be knowing is karyotyping. What is karyotyping? In karyotyping, the circulating lymphocytes are taken and they are arrested in their metaphase, and then you analyze them for the chromosome. So what do? You take the circulating lymphocytes and they arrest at the metaphase, and they are stained using a special stain known as Giemsa stain. And then you analyze for the presence of the various aneuploidies we have already mentioned. Then another option for chromosomal analysis is FISH, fluorescent in situ hybridization. FISH is a method that we predominantly use for the diagnosis of microdeletions. Examples: Dijot syndrome, Williams syndrome, etc. In all these syndromes, what we use is something known as FISH. Then you have something, the last one is chromosomal microarray, CMA. Chromosomal microarray is used for the detection of copy number variation. We mainly detect the copy number variation with the help of chromosomal microarray, and this is mainly used in the diagnosis of autistic spectrum disorders and intellectual disabilities. So CMA or copy number variation. So CMA or chromosomal microarray is mainly used for the detection of copy number variations. So these are the three important commonly used genetic tests with which all these aneuploidies and different chromosomal errors are detected. Okay. So with this, we have come to the end of our second live session. The important questions from various pertaining areas have been discussed. So this is the second part. We have an initial live session already done few weeks back. So please listen to that also. All the important core topic areas, especially from general pediatrics, which is very important for your upcoming NEET PG examination, has been covered. All the discussions has been made based on the previous year asked questions and the previous year asked high yielding areas. So all the best for your upcoming examination. See you soon.